do this screen sharing.
Okay, Dana.
YouTube. You
Screen
start the
share মানে
screen.
শুধু ওপরের স্ক্রিনটা তো শুধু
Just the Onc-o-quest finals and don't fiddle with your bas. Let it stay like this.
আর কিছু করবি না যাতে পরের ওই স্ক্রিনটা না আসে। Be very
Yes,
very
yes.
careful. Be very very careful.
আসছে না তো
না
আর কিছু চেঞ্জ করবি না মাঝখানে।
না কিছু করছি না। আচ্ছা টোটাল 8 জন এসেছে এখনো। YouTube লাইভ স্টার্ট হয়ে গেছে। YouTube live started. Yeah, YouTube live started. Hello, Anivanda.
Yes, you can disable it. তুই কি বলছিস?
Dada, I am telling that like can we share this link to the prep group such that they can join and watch
দাঁড়া হ্যাঁ দেখবে তুই দাঁড়া ready হোক
let the participants join first fully, then we'll share it to the prelims group. We'll share it to the prelims group.
Anna just disable the live chat option in the YouTube.
I told him keep some 5 or 10 seconds lag if possible. participants দের ঢুকতে দে রে।
অ্যাডমিট করছি না করে দেবো সবাইকে অ্যাডমিট হ্যালো
You simultaneously check what I am sending you on WhatsApp, okay? So that we don't goof up on YouTube live. ঠিক আছে?
हेलो जाग रहे हो ना
Yes. हाँ, yes, Dhaneshwar.
मैं नींद में हूँ भाई अभी भी मैं दोपहर पूरा सो के पता है लेजिट
Team treatment, your mic is on.
यही थी भाई।
Shubhabrato, has all the participants joined? Hello? 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 Shubhabrato?
Hello.
How many people have joined?
As of now, 11 participants have joined.
So the finalists, the finalists have joined. Like only one is left, or all have joined.
Only one left, I think. Yeah.
From
Total
which
12
team?
participants. Wait.
Vidyasagar is left, huh?
Vidyasagar is not there, I think.
Yeah,
I'm here.
Vidyasagar.
I'm here only.
Vidyasagar, are you the Zoom user? Hello?
Oh, I'll change my name 1 minute.
Yeah, please change your name. Hello? I think Mrs. Shukla is not there. From Team Scorpion.
Mr.
Sorry, Mr. Shukla from Azad Medical College. Team Scorpion King is not there, I think. Rest all have joined.
Balaji is here. Balaji Shukla is there in the meeting.
So from each team, like from team Scorpion King, the two of you, can you introduce yourself once? And we'll just make sure everybody is there in the call and then we'll start.
मैं कर रहा हूँ पहले, ठीक है? हाँ. Hello, I am Armaan Seth, a final year student from JIPMER Medical College.
Okay.
Hello. Hello, I am Balaji Shukla, final year student from JIPMER Medical College.
Okay. So next is team Beta Catenin.
I'm Aswin from second year, ESIC Medical College, Chennai.
Okay. Your teammate?
Hello, Dakshin, you're not audible.
Dakshin, you're not audible.
Hello, Mr. Dakshin, your audio is muted. Can you make it faster?
No, it's not muted, but it's not coming. No
Hello?
voice is coming.
Can you hear me?
Yeah. Yeah, go on.
Yeah, I am Dakshin from ESIC Chennai and I am a final year student.
Okay. So next is team Acetyl Boys.
Hello, this is Vidyasagar, final year from JIPMER.
Hello, this is John from JIPMER, intern.
Okay. Next is Shagun and Ibrahim.
Hi, I'm Shagun from Azad Medical College, final year.
Okay.
I'm Ibrahim Ilmi from MAMC, final year.
Okay. Next is team treatment, team RX.
Well,
Hello, this is Saumitra Ginodia, third year student from Seth Medical College, Mumbai.
hello, this is Manav Shah, third year student from Seth GSMC, Mumbai.
Okay. And so the last team is Onc-o-quest.
Hello, I am Bikash Sahoo from second year MBBS from JIPMER.
This is Saravanan, second year MBBS from JIPMER.
Okay. So we have 6 teams here. So what we will do is
1 second, just 1 second. Shagun, Batra, could you please check your audio once again?
Hello, am I audible?
Yeah, it's barely audible.
It's very feeble though, but it's fine. If you can improve, you see. Otherwise, go on with it.
Hello. Am I? I'll have to speak loudly, I guess. I don't have any other option.
हाँ वही नहीं तो ठीक है सुनाई दे रहा है. Okay. Anirban,
Yes, so good evening, one and all. So first of all, I would like to congratulate all top 6 finalists for reaching the stage they have made till here. So finally, we have introduced our finalists, and soon after sorting out the teams, there will be team A to F, right? So we'll choose as per the rank list. We'll choose each teams and A to F. So first, I like the team Scorpion King. Armaan said, can you choose one alphabet from A to F? Which team you would like to choose? And scorers, please note this. Note with the team name and the team members. You please note which team each one is choosing. And it won't be like the previous rank, which had been according to prelims. Now, all things will be changed and as per what they have chosen, right? So team Scorpion King, can you choose one alphabet?
We would like C.
Okay, so team Scorpion King chooses C. Team C. Scorers, please note. And now the team from ESIC Chennai, Beta Catenin, can you please tell one team name and the team number?
We'll choose team D.
B for Bombay.
Team D.
So the team from ESI Chennai, Beta Catenin, choose team D. D for Delhi. Scorers, please note that.
For Delhi.
Yes. And now we'll invite the team from JIPMER, Acetyl Broase, to choose
Team
one
F.
number. So Acetyl Broase choose team F. Please note. And we'll now move on to the team from MAMC. Again, a team from MAMC, Shagun and Ibrahim. Can you choose one alphabet?
Team F. Team E. Team E.
Team E. Okay, fine. And now the team from Seth GS Medical College. Only 2 numbers are left now.
BB. Team B.
Okay, fine. You are team B. And so Saravanan and Bikash, the C Onker team has only one option left, that is team A. So scorers, please note this meticulously. Team A is the team from JIPMER, C Oncor. Team B is from Seth Medical College, team treatment. And the team C is from MAMC, Scorpion King. The team D is Beta Catenin from ESIC Medical College. The team E is from MAMC Delhi. And the team F is again from JIPMER, Acetyl Broase. So now we'll wait for some 1 minute so that we can go live on YouTube.
In the meanwhile, can you just rename yourself according to your team like team A, then your name. So just rename yourselves like team A1, then your name, and team A2, your name, like that.
Is the screen visible to all?
I can't see it. उसमें it says that that person has started screen sharing, but कुछ दिख नहीं है.
Then I am able to see it. So can you check once your net?
I'll
I think.
leave and join again. If
Okay,
it's
okay, fine.
Yeah, I can see it now.
Okay, fine then. We'll start the quiz right now. So the basic instructions I would like to give, I have not mentioned it in any slide because they're very generic. So all of you, please keep your videos on. All the participants, the scorers and others, please note whether all the participants' videos are on, and they should be on every time in the quiz. But only when your turn comes, you should speak, and otherwise, please keep your audios muted. And we would like have basically 5 rounds in this quiz, and now we have sorted all the team alphabets and each team names. So we'll first move on to the first round here. So everybody can hear me, and am I audible?
Yeah.
Okay, fine. So fine, we'll now begin the quiz. So it has been a very 3-week old journey for us, and we had 174 registrations to the prelims, out of which 131 responses were recorded till the time we had the prelims on till 7:45. We started at 7. It was a 50 MCQ quiz, and out of these we got 131 responses, and out of them we chose 6 top finalists, and now here we'll be hosting the grand finale. So now we'll move on to the basic schema of the quiz here. Now, can you move to the next slide? So basically there are 5 rounds. The first round, that will be a reasoning based round. And the second round will be a cases round. The third round will be an images or connection based round. The fourth round will be a mega connect. This round is basically you will have one common theme and 3 subparts will be there. Right. So you will have to answer all those 3 and you will come to a common theme, which again points will be there for each subpart and the common theme. And the last but not the least, you will have rapid fire. So can we move to the next slide? So yes, so now we'll start the first round of the quiz. Just get ready for brainstorming whatever gray matter you have. Now we'll begin with the thinker round, the first round. It's a reasoning based round. Just be logical. Be factual. But first of all, you have to be logical. Whatever thing you say, you have to justify that. You will be given 2 statements or 1 statement. You will have to justify them. There will be marks based on your justification. If you just say a true or false, you won't be given any marks. So can we move on to the rules officially? So each team will be provided with 1 question to answer. A statement will be provided. It can be 2 statements or a single statement. You have to say whether it is true or false and with a reason. Just stating true or false won't fetch you any marks. Each question carries 20 marks. There will be a 7th question apart from the 6 regular, which would be open to all. And you have to type the answer to the quiz master personally, right? And if you correct that fully, you will get 20 marks. An incomplete or wrong answer will fetch you a minus of 20 marks there. So that's about the 7th question. You have to answer it fully to the quiz master. It might be a para, but you have to answer it fully to the quiz master, right? So there will be no and if you know the answer, then you're well. If you're very sure, then you can speak if no one else answers, but that won't fetch you any marks, right? So there will be no negative marking here, and the time limit, I think we can relax this time minutes to 45 seconds here, because there will be 2 statements, but they will be related, I am assuring you. So you will have to take 45 seconds after quizmaster reads the question, after I read the question. The scorers also please note this, right? So quizmaster's decision is final. So now we'll move on to question 1. So team A, see Ankur, are you ready?
Yes. Yes.
And anybody has any doubts in this round rules?
The 7th question will type to Anirban or Subrata.
No, you will type to Anirban. Me, I am hosting the round, right?
There are 2 Anirban, one with small and one is in capitals.
Wait. Yes. With one with the small one, I am speaking, right? So you will.
Okay.
So basically now we'll begin with the first team A. That's team C, Oncar. So can we move on to the first question? Shoburto. So yes, I'll read out the question, and after you read out, I'll tell that your time starts now, and you have to think and tell the answer within 45 seconds. Will not be that stringent that you won't be able to answer after 45 seconds, but please do answer after 45 seconds. We won't entertain too much extra time. So first statement is, men die with prostate cancer rather than of prostate cancer. Risk is increased with Western diet, that is animal fats and red meat. So are these statements true or false? You have to tell me, and you have to state the reason reasonably here. So your time starts now. The timekeeper, please tell whenever the time is left, some notification for the participants to hurry up, speed up their thinking process. So read the statement carefully. Men die with prostate cancer rather than of prostate cancer.
5 seconds remaining.
So 10 seconds remaining.
Hello?
Yes. Yes.
Yeah.
Can I have you on?
The first statement is true.
So why? Why is it true?
This is because the prostate cancer, they mainly die of the complications, like if there is vertebral metastasis or something.
So no,
like metastasis.
No, that is because the patient is having prostate cancer, right? It's not because he won't have a prostate cancer because of any other. He won't have a complication if any other cancer will be there. Please specify. Listen. The patient is dying with prostate cancer rather than of prostate cancer. What does that mean?
That means it is not that much aggressive.
Yes, you have to complete your answer. Why it is not aggressive? Can you say some? Can you say what's the reason why they die with prostate cancer and rather than of prostate cancer? I won't accept this because it's not a full answer. I'll give you 10 more seconds. Please speed up. And the second statement, if you want to substantiate that.
Hello?
Yes.
Hello?
Yes. You can speak.
Second is also true because red meat contains some carcinogen.
Yes, carcinogen we all know. That's why that's very obvious. You can tell that for every cancer, I will tell the person may smoke. The person has been exposed to some carcinogen. You have to tell me the answer. What specific things? Why prostate cancer and some other cancers like colorectal cancer, GI cancers, they have increased risk? for with Western diet? I want this.
The aromatic hydrocarbons are more in that Western diet.
Yes.
So
Complete
that
the
is
answer.
increased.
Complete the answer.
What aromatic hydrocarbons are known
do?
as carcinogens, which is increased in
Type of
Western diet.
carcinogen?
So,
What type of carcinogen? How do they cause carcinogenesis?
They cause by DNA strand, they get substituted.
Okay. I'll accept that. I'll accept this, but it's half of the answer what I was looking for. So, okay. Scorer, please. And can you answer the first one? I don't think I can give you more time. Sorry.
First one is prostate cancer itself is not aggressive, but it metastasis to brain through vertebral veins. So it can cause brain metastasis can be aggressive.
So, okay, you have tried. No, that's the reason. No, that's the reason. This is a generalized statement. Men die with prostate cancer rather than of prostate cancer. There are surely men who die of prostate cancer, surely because of its complications, because of the metastasis. But we were asking for a very generalized concept regarding prostate cancer and what is its natural course. So we'll move on to the answer now. So scorers, I can give team 1 5 marks because the second part 10 marks. So we can give them half marks here. So can we move on to the answers? So yes, see, the prostate cancer is itself a very indolent cancer. Like at least 60 to 70% of them are very indolent, and the incidence peaks with age. So by the time the person has prostate cancer and it's in early stage, then there is also an option for observing the patient. If the patient is very frail and he has many comorbidities, why will you go for a surgery? You can just go for serial PSA monitoring and not treat on the patient who is already having so many comorbidities. They die of other related causes like ASCVD, COPD, or other related diseases like complications of diabetes. So these prostate cancers are mostly diagnosed based on autopsy and TURP specimen. These are line directly from Robbins. And this is the situation in our country also, because the most of the patients are very, they present at late stage, right? So whenever you pick them early, observation is a point, but it's not how the natural history of prostate cancer goes. It's by and large an indolent cancer. Understand that. So, and the second reason you told it is partially correct. There are polycyclic aromatic hydrocarbons which create some oxidant stress. As you told, it's an alkylating. It can act as an alkylating carcinogen, but it's indirect. It has to be activated by liver enzymes, and such polymorphisms of glutathione S transferase has been proved that they cause prostate cancer. Like not everybody will develop prostate cancer, right? So with Western diet. So that's the reason. You can see it on your screen, and team A gets 5 points here. So we'll move on to the next question to team B. So here's your question, team B. CA levels need to be measured before surgical management of colorectal cancer. I'm sorry, I've missed that. And CA levels are measured in the beginning of 5th week after surgery. So what are your comments on this? And your 45 seconds of time start now.
Seconds remaining.
Hello.
Yes, you can speak.
So C levels are mainly used for the prognostic indication of the surgery. So we'll measure it before the surgery and after the surgery to know about the efficacy of the patient. So there is no mass which is left behind after the surgery. In case there's metastasis or something.
Yes.
We can find it out because by measuring the CA levels pre and post-op.
No. You will do it for every patient, right? So why do we need to do for every patient? That should be specific, because for every case we'll do one tumor marker before and after. So why specifically we need to measure this CA in colorectal cancers? Like, is it just say what you feel, like why specifically we need to know why CA is like important in prognostication. And don't say please they are secreted or not. Like you have to specify why we need to know the levels preoperatively, not just for prognostication. We have to know it for all cancers, right? Any tumor marker will just measure them beforehand, so to know as whether we have done a complete resection or not. Please, I'll give you 10 more seconds to give the exact answer. Why specifically we need to know how much it is raised?
So CA levels can also be raised in other cancers like pancreas and other GI cancers.
Definite diagnosis. We need to know it specifically.
Second one, I guess, is true.
Yes, you say why? The logic.
CA levels are measured in the beginning of 5th week after surgery. Because in case there is a small mass which is growing, so that will take about 5 weeks.
So why 5 weeks and not 2 weeks? I want to do it 2 weeks. I have left some tumor behind. Why 5 weeks?
Because the detectable level will be made only after 4 weeks, like the level to be detected by the assays.
What's the basis? Your concept is correct. What's the basis of that? Why detectable levels will as you say?
Like depending on the multiplication time of the cells, like if there is more than 10 raised to 6 or 10.
So what's that multiplication time, or could you use a better term? I can give you 1/4 of the mark still for this answer.
So when the mass weight becomes more than 1 gram, maybe then only we can detect it. So
no. The concept here you were getting to it, but you don't know the concept objectively behind this modality of management here. So you would know more about this when you go and read about colorectal cancer, the management part specifically. This is a very interesting topic. So can I move to the answers? I'll explain you. Because CA is not elevated in all cases, all patients of colorectal cancer. There are certain patients who are non-secretors. It happens in many cancers. Like in ovary, as you said, ovary can have some cancers which may have CA levels, and it can have some differentials which have CA elevations again. So that is one thing. But in colorectal cancer, we want to know whether the patient is a secretor or a non-secretor, right? So if it would avoid a false negative, right? It would avoid a false negative. You think that your CA levels are low, so patient is not recurring. The patient won't have anything metastasis, but you are flawed here. The patient will have florid metastasis if you don't record this non-secretor state here. And the next explanation is that half-life of CA is around 7 days. It's 7 days. So the minimum time by which it falls to undetectable levels is 28 days. That's why end of 5th week. Like 4 times it has to fall to get to the trough level. So to check for incomplete surgery, we can check it with best sensitivity when it is supposed to touch the trough levels. So, okay, I can give 2.5 marks chorus to team B. So can we move to the next question to team C? So yes, this is your question. Abscopal effect states that the treatment of disseminated cancer is possible due to effects of a localized radiation on the primary tumor. And the second statement, it gets enhanced by the addition of immune checkpoint inhibitors. So are these statements true? And your time starts now.
Hello.
Yes. 20 seconds remain.
This statement is true because the radiation therapy acts by inducing the DNA breakages in the cells, and that stimulates the P53, the activity of P53, which and other checkpoint inhibitors like P21, which then halt the cell cycle. And the effect of these P53 and P21 is to act themselves as checkpoint inhibitors to the G1 to S transition. So, and that further gets enhanced by the addition of immune checkpoint inhibitors, which would then further act on the same pathway and inhibit this transition.
No, so I want to know what you're talking. You're radiating one tumor locally. So how will it enhance its treatment of the disseminated cancer, right? So you did not explain. You just told the whatever local necrosis will happen, and that's very obvious. We want to know the exact mechanism of abscopal effect, what happens, and why it is enhanced by addition of immune checkpoint inhibitors. Why not any other group of drugs like other monoclonal antibodies? Why only immune checkpoint inhibitors? There lies the answer. If you know this reason for the second, you will be able to say the first one too. So I'll give you 10 to 15 seconds more to say a full answer.
It acts on the dissemination because it stimulates the immunity. Like after the lysis of the local cells, the new antigens are released into the circulation, against which then the immune system is able to mount a response and acts on the disseminated cells. And that is the very reason why immune checkpoint inhibitors are also useful, because they are the PDL1 and PDL2 inhibitors, for example. So they would remove the inhibition from the immune cells in the body, because of which T cells will be able to get activated and destroy the disseminate cancer overall.
No, I want to know the exact mechanism of how radiation helps in this whatever new antigen expression you are talking about. You have to be very
When the
specific.
lysis will happen, the antigen will be released in the circulation. No? That will be recognized by the immune, and also it will be enhanced because the PDL1 pathway will be inhibited. That will lead to the activation of immune system throughout the body. So that's why it can also act on disseminated cancer also, because the immunity has been activated.
So I was looking for two more specific things. So since you did not tell, I can give you here 15 points, but not more. So we'll move on to the answer.
Anirban, you are not audible.
So it causes the upregulation of the tumor antigens via the MHC class 1 molecules. It has to be specific because these MHC class 1 molecules will be presented to CD8 plus T cells and a small proportion to CD4 plus T cells and the corresponding antibody production. This CD8 pathway and MHC1 pathway is classically upregulated when radiation is there, and it has been noted specifically for cancers like melanoma and B cell lymphomas in spleen. So, and now the second reason is that I was looking, the cancer environment is not so simple as you think. There is an immunosuppressive microenvironment which leads to upregulation of these T regulatory cells and receptors like CTLA4 and PDL1 on these cells. And the PD1 receptors are present on those cancer cells which interact and cause an immune evasion of the tumor, and this blocks the activation of T cells. So this radiation causes an increased T cell expression while the immune checkpoint blocks this. So that's why this is called triple blockade. So you had to tell this full like explanation. This MHC1 pathway is the main mechanism by which this tumor cells get amenable to the immune cells of a body, right? So he will give 15 points to team.
Okay. Thank you.
15 points to team C. Now we'll move to team D.
Hello, Anirban.
Yes. Hello.
You are not audible.
Yes. So
Yeah,
can we
you're
move
not.
on to the next question? So the statement goes as such: the FNAC or biopsy is contraindicated in testicular tumors. And the second statement is germ cell tumors arising from neoplasia in situ is classified into seminomatous and non-seminomatous germ cell tumors surgically and pathologically. You have to explain if they're true or false and explain the reason too. Your time starts now. Your 45 seconds of time.
20 seconds remaining. Time's up.
So, Team D, please come up with an answer.
Yeah.
And I won't provide you any hint because it's quite easier than the other ones.
First one is true.
Yes, say the reason.
Because of the risk of recurrence and spread of the malignant cells.
Oh, so, okay. So why don't we do it for any other cancers? Like we do FNSC for thyroid cancer. We do FNSC for other things like in any other soft tissue sarcomas. We also go for FNSC, true cut biopsy. So why in this tumor? Why in this tumor it's contraindicated? I won't give you extra time. You have to answer within 10 seconds the second part also.
So second one is false. Because it's only for neoplasia and not for in situ maybe.
Arising from. Okay, we'll consider your first answer. So no, it's true actually. Now I'll go on to the answers here. So participants, please read the questions first. And so the answer here we were expecting is that exact typing of seminomas, there are 2 points. The exact typing of seminomas and non-seminomatous germ cell tumors are not possible with an FNAC or a biopsy. We need a proper histopathological specimen after removing the tumor en bloc. And the thing why the needle tract recurrence occurs is because of the tunica breach. Specifically, the tunica albuginea is a strong barrier for the testicular tumors to spread to the layers of scrotum. So that is a very important point. In other tumors like thyroid or breast, there is no such capsule. Even if a capsule is there, it can get invaded. Like in follicular thyroid carcinoma, one of the diagnostic features is you have to have a capsular vascular invasion. But in testicular tumors, you need to have a tunica albuginea breach, which is only possible with a biopsy or a FNAC. Otherwise, it is very rare that these testicular tumors present at advanced T stages. Rather, they present at N or M rather than an advanced T stage. And the seminomatous and non-seminomatous tumors obviously differ on the basis of their metastatic features like early mets, hematogenous mode in non-seminomatous tumors. And the response to radiotherapy is also very marked between seminomatous and non-seminomatous. And pathologically, the markers are obviously different. And the latter is often a mixed variant. So the team D don't get any marks in this round. So we'll move on to the next question for team E. Team E, please get ready. So this is a single question. And this is a very smart question. In cases of radical neck dissection of both sides in head and neck cancer, operate on the lesser tumor burdened lymph draining site first. Like there is a right side, there is a left side. Your right side is burden more, your left side is burden less. Which side you will involve, like you will dissect first? You have to explain me the reason here. Why you will dissect the greater side or why you will dissect the lesser side first? You get 45 seconds and your time starts now.
Twenty seconds remaining.
You know this or you don't know this? It's a bit tougher on the tougher side.
Time's up.
So team E, can you come up with an answer?
Yes, the statement seems false, and I think we'll do first on the more burdened side.
So explain why.
Uh, Slightly hard to explain. I don't have an explanation. Sorry.
Okay, so team E won't be getting any point here. I agree this was on the tougher part, but in the quiz it happens like that. One will be tough and one will be easier. So you will be, it will be interesting. I can assure you. So can we move on to the answer slide? So basically, the statement is true. We don't want to burden the teams with some unknown facts. Rather, we'll ask them to answer it why it's true. So that was the main part, so that we can learn why this is true, why this statement is true, and you have to know the reasoning. So both IJVs can never be ligated in any kind of radical neck dissection, even if you want. So due to the risk of fatal cerebral edema. So assuming IJV may need to be sacrificed on the more involved side due to more technical difficulties on that side, we always start from the side where IJV preservation is more likely. So if IJV preservation is achieved, then the surgeon can go ahead with radical neck dissection on the greater affected side. Like he has no other headache of preserving the IJV on the other affected side. Suppose you operate the IJV on the more involved side, and you have to sacrifice the IJV on that side, and then move on to the other side. Now, this lesser involved side, due to your technical glitch or technical fault, you injure that side also. So the patient will now invariably develop cerebral edema. On the contrary, if you inadvertently injure the lesser involved side first, you can abandon the procedure on the greater involved side. You can wait for 6 to 8 weeks for the collaterals to form. For the collaterals to form to the IJV, so that you can carry out another operation on the other side, where you can sacrifice the IJV on that side. It would be a more cleaner dissection on that side, on the greater involved side. And you don't have to worry about another IJV preserving surgery on this side, because already collaterals have developed and you have dissected on this side, on the lesser involved side. So yes, this was a kind of a tricky question. So now we'll move on to the next question. So team 6, your question lies like this. Patients with AIDS have an high incidence of certain tumors, especially Kaposi sarcoma, B-cell lymphoma, and cervical cancer in women, and anal cancer in men. In the era of effective antiretroviral therapy, there is a dramatic decline in AIDS-related Kaposi sarcoma, where the overall rate of lymphoma in HIV-infected population remains elevated.
First one, why the patients with AIDS have higher incidence of Kaposi sarcoma and various other cancers is because of loss of CD4 cells, which are required for immune surveillance in the body. So when the CD4 counts are reduced, then this immune surveillance of the body is lost. So they're more prone to develop such cancers like Kaposi sarcoma, B-cell lymphoma, and cervical cancer.
So what does this T-cell immunity keep a check when it's there? The specific thing about this virus and the tumors. And why not in steroids? Like in steroid use, in chronic steroid use, you might not find these cancers, no? But in HIV, there is a classical increase of 300 times the risk compared to other steroid use or immunosuppressant use. Why in AIDS? It has to be specific. I can give you marks for that, half the marks for that. And you have to elaborate the second reason also. Mind, I'll give you 20 more seconds to elaborate the second statement.
Lymphoma in the HIV-infected population remains elevated because the lymphomas and leukemias are mainly occurring due to in situ mutation rather than from any
yes.
It does not have much what do you say, like with immunity, it does not have much correlation with immunity.
So why does it increase in HIV compared to immunocompetent?
Because of HIV associated proteins which act like oncogene, oncogene, so they
no,
increase the
no.
chance of cancer.
No, not like that. You answered it partially. You were going there, but I can give you more time because the other participants also I can give you 10 marks here. You said both are true and you explained partly, but I would have been more. You could have been more specific. You were getting to the point, but it was kind of specific
Oh,
and
okay,
it's
okay.
kind of very.
In HIV, oh, wait one sec. In HIV, the CD4 is reduced, and
That
there
is
is
for the first point.
okay, yeah, okay. Then lymphomas are still high because mainly the B cell lymphomas are mainly high because B cells are like hyper-regulated. CD4
So
count is
why? So why after initiation of HRT there is no change? If there had been a B cell thing you talked about.
because the initiation has already occurred, I think.
Okay, yes. I can give 7.5. You took 2 extra time. I can give you full marks. I can give you 5 points, 7.5 for the first and 7.5 for the next. It was quite close and it was a very good deduction. That's how reasoning goes. You have to deduce even if you don't know a reason. You have to know the logic. It was very clever quizzing from team F, I must say. So we'll move on to the answers here. Next slide. So the increased risk of malignancy in AIDS exists mainly because of failure to contain the infections and reactivation of viruses, and the decreased immunity against tumors. The main thing is that just an Kaposi sarcoma virus infection is not sufficient. The cofactor here for the Kaposi sarcoma to occur is the immunosuppression. The CD8 cells and the CD4 plus cells which are depleted in this condition. And there is also an impaired macrophage function. Also, the second reason, why not in other immunosuppression? Why not in other kinds of immunosuppression? There is an increased IL-6 and antigenic challenge which reactivate the memory B cells in patients with early HIV, mind you, with latent EBV, and they undergo uncontrolled proliferation due to and lead to aggressive lymphomas like CNS lymphomas. Note that IL-6 is elevated because there is an intrinsic defect in the activation of B cells here. So we'll move on to the next reason. So we'll move on to the next slide. The next slide, the reason is the team said it right because there is an initial germinal center hyperplasia has already occurred before the patient is diagnosed with HIV. So even ARTs won't work because already the germ cell hyperplasia has worked, right? So they won't hamper your course of the B cell. So because there's an increased pool of B cell precursors, and these increased B cell precursors have increased probability, right, to have some functional defects when they undergo somatic hypermutation or when they undergo IG switching. Those are very error-prone regions of the B cell expression. So that's why they will have an increased risk compared to the immunocompetent setting. So every team has answered some things. Now we'll move on to the team common question. Each team, please get ready. I will give you exact 45 seconds and I won't give any extra time to for the answers to come. So can you move on to the next question for the 7th question? And it will be in private chat, mind you. Any kind of official group you type, I won't consider your answer. And you will leak out the answer to your competitors. The question goes like this. Burkitt's lymphoma is a high-grade tumor because almost all malignant cells are infected with EBV and express EBV proteins. So just reason it out and give me a complete answer. There are 3 reasons, but I'll accept 2 reasons. Not less than that. Scorers, tell me when 45 seconds are over. And listen, there is negative marking here. So if you are not sure, there are negative markings here. Please, only if you are very sure, you can say that.
Ten seconds remaining.
No answers from your side. I'll give you 20 more extra seconds. Please reason out if anyone wants to dare and answer this plus 20 or minus 20.
Time's up.
So 30 seconds are over. No one dared to answer this. There was a whopping minus 20 with it. That's why maybe everyone wants to play safe. But let's see how long we will play safe. There will be negative marking some other round. So basically we'll move on to the answer. Basically, it was kind of easier question because EBV is only associated with 20 to 30% cases of sporadic Burkitt's lymphoma outside the endemic setting. It was one reason. Because EBV acts as a polyclonal B cell mitogen. And in these areas, not only EBV is present, but falciparum malady is also present, which compound to the B cell activation here. And EBV merely plays a role in the initial proliferation and not in the direct oncogenesis here. It's just an innocent bystander, as Robin says. It sets the stage because of an increased proliferation, but most of the cells which are Burkitt's lymphoma cells, they don't express this LMP1 and EBN2A, which are very characteristic of EBV infected cells. So there you go. The reasoning was false because of this simple reason that it's not directly oncogenic. It's directly merely an initiator per se and not a direct carcinogen here. That's the concept that we all must know regarding Burkitt's lymphoma and EBV and its association with EBV. Now we'll move ahead with a case round now. So I'll ask Anantaraman to begin the case round here. And I thank all of you for reasoning out and expending some of your gray matter to this unique round in which I wanted some specific answers and most of you tried to answer. And so Anantaraman will continue the clinical case rounds.
Thanks, Anirban. Hello, this is Anantaraman. And I'm going to conduct this clinical case round. Are the teams able to hear me clearly?
Yeah,
you can unmute and answer. Okay, no interference, nothing.
Yes.
So we'll move ahead with the rules. Rules,
Anant,
please.
Anant, we'll start from team B first this time, huh? Otherwise, every time team B is getting.
Oh, okay, fine. Okay, team B will be first, fine. Okay, each team will get one case in this round. So there will be a brief, there will be a case description followed by 2 questions. First, you have to find the diagnosis. For that, I will give 30 seconds once I have completed reading the question. So you have to read the question along with me. Once I complete, there will be a 30 seconds timer. Within that, you have to answer. There will be a pounce window. It will be open only for the diagnosis and other teams can also pounce. So pounce will have both, the pounce will have negative marks and direct questions won't have any negatives. First of all, your diagnosis should be the most plausible one. It should not be a rare manifestation of a common disease or common manifestation of a rare disease. Like there will be some typical appearances, typical clinical features for a disease, only that you have to tell. And once you get the diagnosis, we'll be moving to the sub questions. You have to answer that again within 30 seconds. So sub questions are not open to other teams. Only the concerned team will be able to answer it. It's closed for pounds. Diagnosis, everyone can pounce. Once, like you send it to me. I am Anantaraman. You can send a direct message to me within 30 seconds time limit. Once I have got the pounds answers, I will ask the team to answer. Like if they are not able to answer or if they are able to answer, you will be getting marks, either positives or negatives. Then sub questions.
What is the negative marking?
I'll tell. I'm just. There is no pass. There is no pass questions. There is no pass. That's why I'm opening it for pounds. There is no pass. Can you go to the score?
Hello. Are we supposed to start answering before the question ends, or are we are supposed to answer after the 30 seconds are over?
Like within the after 30 seconds, sir, I'll tell you when to answer.
Okay, all right. Thank you.
No. Question. Sorry, score. So for the direct, the team which is concerned will get plus 25 for correct diagnosis and plus 20 each for one for each sub question. So totally 65 points can be scored if you answer everything correctly. And on pounds there is negative, plus 25 on right answer, minus 25. Minus 10 on negative, minus 10 on wrong answer. Like if there is a clinical condition, you have to describe it fully. If you are sending answers to me in the private chat box, you don't use any shortcuts, any shortcut method, any abbreviations. You write it fully. If there is a histopathological diagnosis which should be given, you should add that also. Okay. It depends question from question to question. We'll see. Team B, are you ready? We'll start with the first question. Team B.
Yeah, we are ready.
Okay. Any doubts are there? Anyone? There are no doubts, then we can go ahead. First question to Team B. Case 1. History. So a 66-year-old war veteran comes to the emergency with the chief complaints of fever, severe left lower abdominal pain and vomiting for the past 2 days. Vomiting was preceded by nausea and it was bilious in nature. The patient also gives history of inability to pass either stools or flatus since last evening. On probing further, the patient gives history of a vague, dull aching, non-radiating left lower abdominal pain for the past 3 months that was relieved by defecation and altered bowel habits for the past 2 months. That manifested in the form of early morning mucodiarrhea and tenesmus. He also gives history of passing fresh blood in stools on 2 occasions in the last 2 weeks. History of easy fatigability and tiredness present. The patient reports to have lost over 7 kgs in the last 3 months. The direct team can mute, like we are having sound interference here. So there is no negative history, no history of jaundice. There is no change in bowel blood. There is no change in bladder habit. No abdominal distension. No cough with expectoration, dyspnea, hemoptysis, neck swellings, or fecal incontinence. History of DM and hypertension for the past 15 years. No history of similar acute illnesses or any surgical emergencies in the past. Examination. Change slide. Okay. The patient is alert and oriented. Pulse is 88 beats per minute. BP is high. SpO2 is normal. He is febrile. Pallor is present. No icterocinosis, clubbing, lymphadenopathy, edema. No signs of TB or abdominal malignancy seen. CVS S1 S2 present. CVS RS normal. Perabdomen is soft. Skin over the abdomen is normal. No local warmth. Left lateral quadrant tenderness noted. A firm immobile mass is palpated in the left lateral quadrant. It is 9 centimeters inferior to the costal margin in the midclavicular line with an ill-defined lower border and irregular surface. No organomegaly noted. Digital rectal examination and proctoscopy. Both the external anal sphincter and internal anal sphincter patent. Bleeding is present. No fissures noted. Anterior rectal wall is free. A firm immobile mass is noted in the posterior and left lateral walls of the upper 1/3 of the rectum. Next slide. Investigation. USG. A 4 into 5 centimeter hypoechoic mass is noted in the sigmoid colon. It is extending into the superior rectum with mural thickening of sigmoid and presence of diverticula. Ureter and retroperitoneum uninvolved. Free fluid is noted in the abdomen. Endorectal ultrasound. It is consistent with the USG findings, and 2 lymph node enlargements are noted with the mass penetrating into the serosa. Lower border of the mass is 4.4 centimeter above the dentate line. CT abdomen. USG findings are confirmed. The mass does not breach the serosa or infiltrate the nearby organs. No fistulae found. Localized bowel wall thickening and pericolonic fat standing present. Sigmoid shows irregular lumen with a spiculated outer border. Should I move to like any history or examination in any teams want?
The time starts now. 1 minute will be there.
Anyone needs to move to any slide, you can tell, we will see.
What do we have to answer in this? The staging or what?
No, if you want to give a complete answer, you can give. Like I need the anatomical location of the tumor. Whatever clues you get from history.
30 seconds remaining.
You want to go to the history? Any team wants to go to the history or?
So the diagnosis is sigmoidorectal cancer, and staging is
Wait.
T3.
Wait. Anyone is bouncing? Okay. Team 5, John, they have pounced. Their answer is what to say. They have not given the anatomical location properly. Staging is fine, but staging is also not fine. Okay, team 5 will be getting. We'll see. Okay, any other teams bouncing? I'll close the pounce in 5, 4, 3, 2, 1. Okay, pounce is closed. Team B, you can start answering.
So the diagnosis is rectosigmoid cancer, and the staging is T3N1M0.
Okay, fine. No, what clues you get in this case? Like you give a brief explanation. 1 minute. Give a brief explanation, then we'll move to the sub questions. You are right. Team B gets 25 points for the diagnosis. Well done. Team B, you can explain how did you arrive at the diagnosis. Team B.
Hello, yeah.
Yeah. You explain, no? How did you come? How did you arrive at the diagnosis? Like, why sigmoid or rectal? And
So the patient
what
is
is
having
the
symptoms of obstruction since some time, and he has history of
no.
rectal bleeding also.
What is the current problem for this patient? Okay, it's sigmoid or rectal carcinoma. What is the current problem for this patient?
So the problem is he's having bleeding as well as signs of obstruction.
No. Why is he going to the emergency then? He has to come to the OPD, no? Bleeding, fine. Patients will come to there is no acute massive episode of bleeding, no?
So then diverticulitis?
Yeah, diverticulitis.
Acute diverticulitis is presenting to the emergency department.
Yes, right. Generally, some sigmoid cancers might present as acute diverticulitis.
Yeah.
So this patient has presented with acute diverticulitis.
Yes, sir.
Fine. You have got both parts of the question right. Fine. The next slide. Like there is rectal involvement is there. You see, no, the early morning mucoid area that is suggestive of rectal involvement, and DRE also shows rectal deposits. And CT abdomen USG shows sigmoid colon involvement. Sub questions. 30 seconds. Just 30 seconds. Brief management. In this patient, not generally. In this patient, what will you do?
Hello. So the most common.
Tell me. I'm able to hear you.
So the most common thing, if the patient is stable, we'll go for the resection of the lesion and we'll go for proximal diversion, which is called as Hartmann's operation.
Okay.
And the patient is not if the patient is not stable, this is what we do. If the patient is stable, then we'll go for a primary resection and anastomosis.
Okay, you say then what will you do? Then
Hello,
What
क्या
is the
करेंगे?
definitive procedure in this case? Definitively, what will you do? True lines only.
We'll have a Hartmann's procedure will done, na? So we'll
Okay, fine. First,
make
that
an
is over.
ileal pouch.
Team B,
Hello?
you have voice break. Fine. Can ask
And
the
the
other
use of
person to answer
genetic
also.
testing.
So
Basically,
first,
the colorectal. Huh?
first question only you have not completed. First question you complete first. Acutely you have done Hartmann's procedure. Then now the patient is stable. What is the definitive procedure in this case? Like is
We'll
the
go for a
resection
primary
enough?
dissection and anastomosis.
Yeah. Then what will you do? What is the procedure for
अरे
left-sided
procedure
cancers? What is the procedure? Hmm?
So we'll connect the transverse. Hello.
Tell me. I'm able to hear you.
So we'll connect the transverse colon with the.
Okay, you leave.
Yeah, leave.
You
Yeah.
go to the second question.
हेलो तो इसमें FAP है ना?
Because you are overshooting the time limit.
तो क्या बोल रहे हैं?
Second question.
So if the patient is having a family history of APC mutation, that is adenomatous polyposis cancer mutation, there is a 100% chance that the patient will develop colon cancer by the age of 50 years.
Fine.
So we अपन इसमें we can go for a prophylactic colectomy in such patients.
No. 100% chance of developing it means the question itself gives it is APC only. So what is the use of genetic testing further? Like there will be family history. You go to colonoscopy and you find hundreds of polyps, then that is APC only. You don't need to even do genetic testing for it. What is the use of genetic testing in this patient? 5 seconds I will give you. You finish it, we'll go to the answer.
So genetic testing will help you find the other cancers as well if they're there in the body.
No. That will. Okay.
Or else if there's EGFR mutation which is positive, then we have to go for KRAS.
No. This is very specific. Okay. First question they get half points. Okay, because they have told the acute management. First question is for 20 marks, so they will be getting 10 marks. Second question they have got it wrong. We'll go to the answers. Answers. The answer is rectosigmoid carcinoma presenting as acute diverticulitis. The team found it. Well done. So initially the patient suffers from obstruction, so you have to do an Hartmann's procedure under IV antibiotic cover. Later when the inflammation has subsided, you have to do left colectomy with low anterior resection. I expected that answer from you, team B, because there is a rectal involvement also. You understand? No. And I have given also EAS and IAS both are patent. So you do only low anterior resection and not abdominoperineal resection. With the J-loop colonal anastomosis because the tumor lies more than 4 cm from the dentate line. That is a definitive thing. You should have told like Hartmann's procedure. Then once inflammation subsided, perform definitive procedure left colectomy with LAR. Like that you would have told means I would have given you full points. Now I'll give you only 10 points for the first sub question. Second sub question, this is a direct line from Sabistan. Actually here codon studies will be done. Either if the mutation is before the codon 1250 or after codon 1250. If it is after 1250, then there is 3 times increase of rectal cancer. So in some patients rectal sparing surgery will be done. Here it is not possible. So this is a genetic testing which influences your management. That's why I put this question. Fine. Team B gets 25 points for the diagnosis and 10 points for the sub question, so 35 marks. Next case. Team C, this is your question.
Team F pounced, right? What's their fate?
Okay. Team F gets a negative because they have written it's left-sided colorectal cancer and diagnosis is also wrong. T4B, N1B, N0 was a diagnosis, but I have told no.
It's T4A. Subserosal is T3B.
No, it has not penetrated. No, you see. Where did I
That is
put it penetrate?
serosa. Serosa, it's written serosa. It's not written sub-serosa.
See,
Any of it is wrong, right? Leave. It's any of the diagnosis was wrong.
okay, case 2. Team C gets a case, right? Team C?
Yes, da,
Are you
yes,
ready?
yes, da.
Yeah, we are ready.
Continue. You continue, da.
Okay. Okay, we'll be fast now. Okay. We are overshooting. So a 53-year-old postmenopausal P4L4 female presents to your OPD, concerned by a lump in her right breast for 4 months, nipple retraction and discharge for the last 1 month. The lump in the right breast was insidious in onset, progressively increasing in size, initially painless, but the patient developed dull-aching pain in the last 2 months. Patient also noticed a painless, occasionally blood-stained nipple discharge with retraction of nipple in the last 1 month. No history of skin changes, dimpling or change in the color of the breast, contour of the breast. No history of any trauma, fever, cough, dyspnea, loss of appetite, weight loss, jaundice, abdominal pain and distension or bone pain. No history of HRT usage. Patient attained menarche at 17 years, regular cycles, normal menstrual flow. Age at menopause was achieved 1.5 years ago. Age at first childbirth was 25 years. All babies are breastfed. No history of breast cancers in the family. No history of breast cancer in the family. Mother died of CA breast. Sorry. Examination. So, the patient is alert, oriented, pulse, BP, SpO2 normal, pallor is present, CVS RS normal, GIT is also normal. Breast examination, both breasts are symmetrical, nipple is at the same level, left breast is found to be normal. Right breast on inspection, the skin is normal. Nipple retraction present, no puckering, dimpling. Irregular mass is present in the upper outer quadrant, 4 into 4 centimeter. Submammary area is normal. Both breasts fall forward equally and bending, no right supraclavicular fullness. Next slide. Palpation, no local warmth, hard irregular mass is present, like it is 8 centimeter lateral to the parasternal border and 7 centimeter inferior to the clavicle. Skin is pinchable, mass is mobile. Pectoral is measured along the direction with no restriction on muscle contraction. The mass could not be moved independent of the breast tissue. Axilla is single, discrete form, mobile. 3 into 3 centimeter lymph node is felt in the right axilla. The anterior group of lymph nodes. Left axilla was clinically negative. Supraclavicular lymph node, non-lymphadenopathy. True cut biopsy was taken from this mass. So go to the histo slide. So this is a true cut biopsy. Like anyone who is pouncing at team C, you should give a histopathological diagnosis along with the clinical diagnosis. Just 30 seconds for this question. 30 seconds. I'll see the bounce then. Anyone pouncing? Any team? I need the histopathological diagnosis along with the clinical diagnosis.
Oh, we can't like we have to give the histopaths on pounds. We
Yeah,
can't give
that's why we have put the biopsy specimen, no? Biopsy finding, no?
10 seconds remaining.
Till now, no team has found. This is an easy case, actually.
Time's up.
क्या बोलूं बता?
With typing.
You want me to? Okay. Wait. Team F, whether you want me to consider your answer or not, because it has come outside the bounds limit, so I give you an option whether I have to consider your answer or not.
No, don't consider. No, don't.
No. Okay, fine. Okay. Team C, you can start answering now. No team has sponsored actually. Team F told no.
This is a case of invasive ductal carcinoma, and it is T2N1M0.
Fine. No. Histopathological diagnosis along with the histopathological. I want histopathological diagnosis. Everyone knows it's breast cancer from the history.
Okay, just a sec.
5 seconds, sir. 5, 4.
The luminal variety, the not otherwise specified NOS. No,
this is very classic appearance actually. What do you see here? Like there is some space, there is some group of tumor cells.
Okay. Mucinous
I'll
वाला
give you
भी नहीं
5
होता है?
seconds.
Mucinous नहीं.
Is this the medullary variant?
No, this is not the medullary variant. Okay, fine. We'll go to sub questions.
Okay.
I'll tell the diagnosis at last actually. Very easy. T&M score you already told, I think. What is the score?
Okay. T2N1M0.
Okay. What is okay? This go. If you go to histopathology, most common, most probable receptor status I need. You can't refine your diagnosis now. Your diagnosis time is over.
Okay.
हेलो अरमान.
हाँ बोल.
ल्यूमिनल तो नहीं था, फिर क्या बोलते हैं? HER2 पॉजिटिव. नहीं, BRCA1 वाला होगा फिर.
This is a triple negative status.
Okay, fine. Okay, now outline the management.
For
Wait, you didn't tell me the stage. What is the stage?
It is T2N1 stage cancer.
Stage.
Stage 2. Stage 2 cancer. Locally advanced breast cancer. So first we give neoadjuvant chemotherapy followed by modified radical mastectomy.
Then
followed by post-operative chemotherapy, since it's a hormone receptor negative and the woman is a post-menopausal group, so we add letrozole to her.
Okay, then we'll go for the answers. Okay, this is a micropapillary carcinoma actually. Medullary, there is no pushing border, there is no infiltratory margins. So here there is a hollow balls of tumor cells floating in a clear space. Actually here micropapillary because there is no fibrovascular core. You will be seeing, no? Can you go back to the histopath? See, there is no fibrovascular core. There are tumor cells which are concreted in hollow balls separated by a clear space. This clear space generally defines lymphovascular invasion in this case. Actually, this is a tumor which is very much prone for lymphovascular invasion. Lymph node metastasis early and it is aggressive also. Answer slide. Actually, this is a HER2 positive cancer. So your management should be done according to that. You are right with T&M classification T2N1M0 clinically. Stage 2B, I think you told stage 2, not 2A or 2B. You didn't mention, no? You didn't specify that.
No, I told stage 2 only.
Okay, fine. Hormone status, ERPR, HER2 positive. Management, it depends on the tumor breast ratio. If contraindications of BCS is there, MRM is done with post-op adjuvant chemotherapy with trastuzumab and CADFEC 6 cycles. Trastuzumab should be continued at least for 1 year and endocrine therapy is then started, tamoxifen letrozole. This patient is recently postmenopausal, no? So you can give tamoxifen also. And if it is suitable for suitable indications, go for BCS. Here it is 4 cm tumor. So BCS generally it can be done if the tumor, depending on the tumor breast ratio. So depending on the surgery, we use RT. If there is any margin positive or any indication to axilla posterior section, you have to give RT. So I think you will be getting. I will give you marks for. I will give you marks for that stage. Okay. So first question you have completed half, so it will be 10 points. And diagnosis, you told medullary carcinoma. I don't think I can give you any marks for that. I wanted the histopathology specifically. That's why I put the slide. So team C will be getting total 10 points in this round. And your management is also wrong because you should have included trastuzumab. Next question, please. Now you would have known how to write the diagnosis, like what we will be expecting. So your diagnosis should be to the point. If there is a histopath, you include histopath. If there is a clue for anatomical location of tumor, include that. Phase 3 will start. Team D will be getting. Team D, no? Team D, are you ready?
Yes, we are ready.
Okay, fine. A 35-year-old female presents to the emergency in acute distress with complaints of sudden onset breathlessness and chest pain for the past 1 hour. Breathlessness was sudden in onset and progressively worsening with stabbing right-sided chest pain, radiating to the ipsilateral shoulder, increasing on inspiration. Further probing, her husband revealed that she has been having progressive breathlessness in the last 6 months, initially during exercise, laterally occurred even with daily activities. History of cough with thick whitish expectoration present for the past 3 months. The patient also complained of abdominal pain worsening after heavy meals with nausea and bloating sensation. The patient is currently under fertility treatment for the past 1 year after 7 years of unsuccessful cohabitation with her husband. History of dysmenorrhea present. No history of similar complaints in the past or TB contacts or similar illness in the family. She was evaluated to have same complaints previously and was diagnosed with asthma, and she was also started on bronchodilators with no clinical improvement. History of smoking, no history of smoking or exposure to smoke. Next slide, please. It's an RS case. So the patient is alert. Now this patient is under distress. Pulse rate is high, 124. BP is somewhat low, 98/70. SpO2 is less. She was desaturated actually, 87%. Respiratory rate 34. It is thoracoabdominal with accessory muscle use with respiratory distress, imminent. Pallor is present. Supraclavicular and axillary lymphadenopathy present. There was no specific skin findings to suggest any systemic disease. Respiratory system, skin over chest is normal, trachea is shifted to the left. Palpation revealed absent vocal parameters and hyperresonant note on the right hemithorax, impaired note on the left. On auscultation, breath sounds were absent on the right. Crackles and velcro were heard in the left infra, inter, and axillary areas. CVS is normal except for loud P2 in the pulmonary area, and the P2 was not palpable actually, it was only heard. No murmurs or thrills noted. Next slide. There is, okay, diagnosis. You want to go back to the previous slide? We can go back. This is somewhat tough case. Okay, now the time starts now. The teams can start bouncing. Any teams, if they want to bounce, they can start bouncing. Wait.
Go back to the previous slide.
Previous slide, go back.
9 seconds remaining. Time's up.
Team A, no team A, no, your clinical diagnosis is also wrong actually. No, team A gets a negative mark. Team A gets negative. Bikash has answered, he gets negative. Negative, -10 to team A. Anyone is bouncing? Hey, time is over. Huh?
Yeah, time is over.
Okay, no one like team A has sponsored and they have got a -10. So team D, you can start answering now. What do you think this patient has? Team D. Hello, am I audible?
Pulmonary embolism complicated by pulmonary hypertension.
Wait. Pulmonary embolism. You see the respiratory system findings first. Where is pulmonary embolism here? See, there is a indicate. Team D, your speaker is mute. You have to unmute yourself.
Pneumothorax is there.
Okay, fine. Then what is a complete diagnosis? What is the diagnosis? She presented with pneumothorax, right? Team D, you are on. You have to be unmute. Team D. Don't take too much time, man. We have already given in some time. Okay, 5, 4, 3, 2, 1. You have any answers? No. Diagnosis. What do you think? Just to give it a guess, no. If it is right, then you will be walking away with 25 points. Team D. What is your answer? Huh? No, your time is over actually. You have to give an answer. So you can't discuss now, right? Team D. No more time, man, actually. We will go to sub questions. Team D has not given us a clinical diagnosis. Pneumothorax. Yeah, they have only told pneumothorax. Go to the sub questions. They won't be getting any points. Again, will you manage this? Okay, enumerate the X-ray and CT findings and establish a diagnosis. Will establish a diagnosis and manage the case. No one has pounced also. Actually, if I had given some skin findings, this case would have been very easy. I'll give you a clue so that you can answer the CT and X-ray finding. So you notice that milky expectoration, cough with milky expectoration, with one-sided pneumothorax and other side there is a impaired note, no? So there is some interstitial exudate, interstitial infiltration. So one side there is ILD, another side there is pneumothorax. So what could be the possibility? Team D, you have 15 more seconds. That's all. You're taking too much time. We have 3 more cases to finish and other rounds are also there. Have to stick to time. Scorer, keep the time, please. Actually, we'll rush.
Your time's up.
Okay, fine. You answer. Do you have an answer or not? Team D. Team D. Okay, Team D doesn't seem to have an answer to both the sub questions actually. Okay, we'll go to the answers. Team D is not getting any points in this round. Okay, this is a lymphangioliomyomatosis case. This is a sporadic variety of LAM, lymphangioliomyomatosis. Actually, these patients will develop pulmonary cysts in the lung, small and large cysts. Sometimes the cyst can rupture and there will be pneumothorax. That is a presentation in 1/3 of the cases. That's how they will present it. Actually, this patient was on hormonal. Actually, this patient was on treatment for infertility. This is a very common trigger for LAM in females. This is generally a disease for females. So X-ray will reveal the right-sided findings for pneumothorax, which is a hyperinflation with absent bronchovascular markings and mediastinal shift. Left-sided there will be diffuse reticulonodular opacities in this case, predominant in the lower lobe. Generally, it doesn't have any predilection, but sometimes it will have a lower lobe predominance. So HRT, there is a thin-walled, round, well-defined cyst divide of internal section. This is very classic. Thin-walled, round cyst, no internal structure seen throughout the lung. That's how you differentiate it from other cystic conditions. With the pleural thickening, septal thickening, and other features of interstitial lung disease, there is no non-hilar mediastinal lymphadenopathy. Like in hilar mediastinal lymphadenopathy, you will have in sarcoidosis. Here, it is non-hilar. So diagnosis, you do serum HFD test. If it is more than 800 picogram per ml, with features of obstructive lung disease, you can go ahead with surgical lymph node biopsy. Treatment will be sirolimus. Actually, first line is sirolimus. For clinical response, you can start bronchodilators for obstructive lung disease and glucocorticoids. Glucocorticoids are generally found to be useful in this case. Sirolimus is a drug specific for this condition. Okay. Team D will not be getting any points in this round. Next question. Next case to Team E. This is the HRCT picture actually. So there are multiple cysts, thin walled cysts, round cysts. Generally, it's round with the divide of any internal structures. With septal thickening, other features of there is no predilection. You see, both left and right lungs are usually commonly involved. This is other patient, not this patient actually. This patient will have pneumothorax on the side. Shagun, you are about to tell something. You can tell actually.
No. I just unmuted for our question.
Okay, fine. We will move to the next case. Team E. Team E, please be ready. History. So a 8-year-old boy presents to the OPD with chief complaints of difficulty in walking for 3 months, diplopia and headache for 1 month, and facial weakness for 3 days. Difficulty in walking was primarily due to loss of balance and the child's face to the left. It has worsened over the last 3 months. The boy also gives complaints of tremors in the hands and legs. While attempting activities, he is unable to maintain posture. And he has clumsiness along with involuntary movements due to which he is unable to perform even the simple tasks. Patient then developed headache, which was diffuse but increase in intensity in the posterior region with increased severity while waking up in the morning, that is sometimes associated with vomiting not preceded by nausea. Facial weakness is on the left side. The insidious in onset, unheralded, and it is manifested by inability to close the left eye. Slurring of speech and drooling of saliva is present on the left side. Then next slide. So this is a CNS case. The history of reduced appetite for the last 1 month. No history of limb weakness or seizures or abnormal behavior or altered sensorium or bowel bladder disturbance, loss of sensation, no difficulty in swallowing or dizziness. No history of fever, neck stiffness, night sweats, cough, antecedent viral URIs or abnormal breathing, bleeding or reduced urine output. Not a known case of hypertension or sickle cell anemia or any thrombotic disorder. No history of similar complaints in the past. No history of any recent vaccination. The child has achieved all developmental milestones at normal age. No history of similar complaints in the family. Examination. So the child looks ill, but it's alert oriented. Pulse is 98 beats per minute. BP 94/68. RRS 28 per minute. No irregular breathing. Pallor is present. No icterus, cyanosis, clubbing, lymphadenopathy or edema. CVS is normal. RS is normal. CNS examination. Skin, there are no neurocutaneous markers. Higher mental functions. Dysarthria is present, but comprehension is normal. Cranial nerve findings. So there is a left lateral rectus palsy with the left facial nerve palsy, LMN type. Next slide. So motor system, right-sided bulk tone is reduced bilaterally. There is hypotonia. Power is preserved on the right side, but there is mild decrease in the left side in both proximal and distal muscles. Dependent reflexes are normal in the upper limb. Even in the lower limb, bulk is normal, but tone is reduced. Power is preserved. Dependent reflexes on the left side, we were able to elicit a pendular knee jerk. Babinski is bilateral flexor. Cerebellar signs, titubation is present. Nystagmus is present. Finger nerves, there is dysmetria. Intentional tremor is noted. Dystiodocokinesia present. Knee heel test unable to perform. Tandem walking is present. Gait is ataxic gait. Next slide. Sensory examination was normal. So on the basis of this complaint, an MRI was ordered and this is shown below. It's an MRI. So you have to tell me the exact anatomical location of the tumor. I will not accept any. Actually, the diagnosis contained. So there's a 30-second pounce window. The teams can pounce. Team E, be ready with the answer. Anyone is pouncing, you can pounce now.
Ten seconds remaining.
Anyone is pouncing? Team A, Team F.
Time's up.
Hello.
Yeah, okay. Nobody is pouncing. Okay. Team E, you can answer.
This is a medulloblastoma.
Why do you think so? Medulloblastoma. What is the most common site?
Sorry.
Here you see the lesion. Where is the lesion actually? Here you will be able to see.
Posterior fossa lesion.
Posterior fossa. Okay. Posterior fossa. Okay. Where is the lesion exactly actually? See.
It was initially on the left side. It's crossed the midline because there's titubation also, which is a sign of midline involvement.
Fine. Is the vermis involved on the in the posterior side? Is the vermis involved?
Yeah, it's
vermis
involved.
is infiltrated or it is primarily involved?
It is infiltrated.
You can see it. It's infiltrated, no?
Yeah.
Medulloblastoma, the most common site is vermis. It's cerebellum actually, and it
Then
won't be present.
pilocytic astrocytoma.
Diagnostic astrocytoma.
No, your answer, your diagnosis is medulloblastoma actually. That I will take. That's the diagnosis I can take. Okay, we can go to the sub questions. So, what is the most common molecular pathology that is observed in this case? Actually, medulloblastoma won't present with these findings. I'll tell that.
GFAP.
GFAP mutation.
Okay, then how will you manage this case? Can you repeat your answer for the first question again?
GFAP mutation.
Okay, fine. Then how will you manage this case?
EP.
10 more seconds, Ra. If you get this far, you can manage the case also. There are not a lot of options left actually. How many things you can do?
Surgical resection followed by radiotherapy.
Resection. Okay, resection followed by
Followed
radiotherapy.
by
Say answer.
radiotherapy.
Okay, fine. We'll go to the answers. Actually, this is a case of DIPG, diffuse intrinsic pontine glioma. So you have answered medulloblastoma. Generally, medulloblastoma will be primarily involving the vermis, and in very late cases, it will go to the brainstem. So if there is only vermis involvement, then how there will be dysmetria, that is signs of incoordination, dysdiadochokinesia is there. Midline cerebellum lesions won't cause that. No, there will be only titubation and truncal rigidity ataxia. So for a tumor to involve both neocerebellum, parieocerebellum, archicerebellum signs, it has to involve in the brainstem, where it will be infiltrating the cerebral peduncles. This is a case where the main lesion is in pons and it has infiltrating cerebellum a little bit. You can see the peritumoral edema in the cerebellum. That is not the primary lesion. So the diagnosis will be diffuse intrinsic pontine glioma. Mutation. The most common mutation is H3K2A mutation. Like lysine is substituted to methionine. There will be a deregulation of PRC2, which is a regulator of gene expression. So here first we have to reduce a peritumoral edema. You give dexamethasone. So definitive therapy, you cannot do surgery because there is nearby vital structures, you will damage them. So first line is radiotherapy. Very rarely you do surgery. Radiotherapy should include adjacent 1 to 2 cm of the brain tissue. So chemotherapy, actually this is a case which is typically IDH negative. So you cannot give temozolomab. That is given only if it is IDH positive. This is a tumor which is typically IDH negative. So no role of chemotherapy or surgery, only radiation. Actually, this is a very poor prognosis. This case has very poor prognosis. Okay. Team E will also be not getting any marks. I can't accept medulloblastoma. Next slide. Then next question. So team F, are you ready? We'll start. A 70-year-old male presents to medicine OPD with symptoms of low back pain for 7 months, breathlessness for 3 months, dysphagia for 1 month. Lower back pain is localized to the midline, insidious in onset, progressive, radiating. To the right outer thigh in the last 2 months, increased during the night with and subsides with medications. The patient also reports of numbness in the right foot, breathlessness, insidious in onset, NIHA 1, now NIHA 3 with mild dull aching left-sided chest pain on exertion. No history of PND present. Dysphagia is insidious in onset, initially to solids, now has progressed to semi-solid food preparations. History of reduced urine output for the past 1 month. History of EC fatigability and tiredness present. No history of LRT was 1 month, 4 months back. Was treated on OPD basis. No history of abdominal pain, jaundice, hematemesis, melena, altered bowel habits, blood in stools, noxuria or incontinence. No history of similar complaints in the past of TB contacts. This is a case of chronic hypertension for the past 10 years. Next slide. Team F, please, like the moment I stop the moment I stop reading the question, you have to answer within 30 seconds. It's a easy case. Patient is alert, oriented, time, place, and person. Pulse is 68, normal. Respiratory rate is 22, abdominothoracic. Is mildly desaturated 94%, BP is high, pallor is present, bilateral pitting pedal edema is present up to the ankles, no icterus cyanosis clubbing or lymphadenopathy, head to toe examination revealed periorbital purpura and macroglossia, CVS raised JVP, skin over the precardium is normal, grade 1 parasternal hive present, S1 S2 is heard in all 4 areas, no murmurs, RS bilateral crypts are felt in the basal lung fields, MBBS is heard. Next slide. So periabdomen is soft, hepatomegaly present, rounded margin, smooth surface, liver span is 17 centimeter, CNS higher mental functions cranial nerve normal, unilateral motor and sensory normal. So lower limb examination, actually on the right side the power was reduced in the quadriceps and other muscles. Quadriceps anterolateral thigh, quadriceps power is reduced 4/5. Deep and reflexes are normal. Both bilateral Babinski flexor response sensation is normal. Spine examination, tenderness is present in the lower lumbar spine and upper sacrum. Straight leg raise is positive. Next slide. I think it's a diagnosis. Next slide, please. Okay, investigations. CBC anemia is present 8 gram percent. Normocytic normochromic anemia. WBC 4,500. Platelets 98,000. RFT M spike is present. Serum creatinine is raised. Serum electrolytes, calcium 11.8, potassium 5.5, sodium 136. Spine and X-ray report, MRE report was awaited. Okay. Now I open the Pounce window, 30 seconds. I need the complete diagnosis, no part answers. Team F, be ready with your answer, complete answer. Anyone is pouncing? Team F.
10 seconds remaining.
Anyone is pouncing? No one has pounced yet. It's an easy case here.
Time's up.
Wait. Team
Can
B.
we answer?
Wait, 1 minute, 1 minute. Multiple myeloma. Okay, team B. Okay, wait. Okay, you can answer. Team F, you can start answering.
The patient is having lung cancer with the mediastinal involvement and metastasis to the spine. Hello.
Okay. Okay.
Okay. The lung cancer is most likely to be squamous cell carcinoma because of hypercalcemia seen in this patient.
Then
he's having progressive dysphagia due to external compression from by the extension of the lung tumor into the.
Does he have any cough with hemoptysis? Anything? Any lung symptoms?
No, it may or may not have. It can even be esophageal carcinoma, like presenting in
That's
the other way.
That's what I told. No, you tell me the common presenting complaints of a common disease.
Okay, you want like that. Okay, then it can. Then
no,
it
you
is
told
esophageal carcinoma. Going to, he's having aspiration because of that bilateral aspiration. He's having, so he's having like what is that? He's having consolidation. He's having pneumonia both the sides because of aspiration. Then he's having metastasis. Esophageal cancer can metastasis to the spine, and that can cause the following thing.
Okay. How will you explain the abnormal urine analysis picture? What is given in urine analysis?
Urine analysis. Can you come back?
No, I can't go back now. I can't go back.
Hey, you went for others, right? You went for others front and back.
Hey, yeah, you have started answering, no?
How does it matter if I see once?
Okay, fine. We can go back. Anyway, you can't change your diagnosis now. You told lung cancer, but only that I'll take.
Sir, what about team A? We bounced.
I'll tell you the pounce at last. I have seen your answer.
Lung cancer is more common than even esophageal cancer, right? So that's why I told it is.
No. You can go to the urine analysis. One slide back, please. See, urine analysis revealed. M spike.
Multiple myeloma.
Serum creatinine is raised. Patient presenting with lower back pain.
Okay,
fine. So we'll go to the sub questions. Describe the pathognomic cell chromatin appearance. What
Mast
is the
cell
treatment you will consider? What is the treatment you will consider in this patient?
pathognomic cell is MOT cell.
Okay.
Plasma cell will
No,
have
no,
right, and chromatin will. Plasma cell will contain the globules, immunoglobulins, which will
okay.
give it a MOT-like appearance. That is known as MOT cell, and the chromatin appearance is like the cartwheel appearance. Plasma cells, chromatin is like cartwheel appearance. Hello.
Okay, okay. I'm able to hear you. I'm able to hear you.
Did
Can you state the reason for that appearance? Plasma cell appearances are not typical. You tell me the plasma cell appearance actually. Plasma cell, okay. Okay.
Cartwheel-like appearance with perinuclear off.
Can you tell me the reason?
For cartwheel-like appearance.
Both. For both. Okay.
For this MOT cell is due to accumulation of immunoglobulin inside the cells in the multiple immunoglobulin goblets are present. Then
that's for intranuclear. That's for intracytoplasmic inclusion. What is the treatment?
Yeah, that is intracytoplasmic.
What is the
for
treatment?
this patient, right? Treatment is chemotherapy with lenalidomide, dexamethasone, and bortezomib. But you're asking this patient, right?
Yeah, it's given in the question.
No, I'm asking you. I should.
Yeah, in the consider for this patient, this specific patient. 5 seconds, 5 more seconds.
He's having osteolysis, like he's having spinal disorder also. So you have to do fixation, internal fixation of the open reduction internal fixation, because there is a disc. Okay. Then drugs. Okay.
Over. Okay, you have exceeded the time limit actually.
Then he's having progressive dysphagia, I think. So esophageal SEMS you can put, self-expanding metallic stents.
Fine. You can. I think you are okay. Fine. You have exceeded the time limit. We will go for the answers. This is a case of multiple myeloma with amyloidosis actually. See, there is periorbital purpura with macroglacia. There is primary AL amyloidosis. So typical appearance, he told plasma cell with eccentric nucleus, perinuclear halo, vessel bodies. Chromatin is cloth-correct pattern or cartwheel pattern. Vessel bodies are IgG inclusions with perinuclear halo will be that prominent Golgi bodies which is involved in protein production. So the patient, Vidyasagar, you told that the patient will give, you will be giving bortezomib to that patient. Actually, bortezomib is given only if the HSC transplant is done.
Melphalan,
So
if you are planning to give. Okay, fine.
No, this patient is not a clear candidate. No, he has organ dysfunction.
So
you will not be giving him.
It is not like if the patient is not a hematopoietic stem cell transplant, you can give melphalan. It's not like that. If you're planning to give melphalan, you cannot do hematopoietic stem cell transplant because there is high risk of secondary leukemias. So that is the reason. Just because the patient is not a candidate, you cannot give melphalan. Melphalan is
this patient melphalan is first line.
You can check and give. If you want, you can check and give me.
Anyway, you told that bortezomib, so you will not be giving any. The bortezomib we won't give you, no?
Hello? No, it is
See,
not like.
You clearly told there is bortezomib. Here the patient is having organ dysfunction. First of all, bortezomib you cannot give in this patient. AL amyloidosis is there, bortezomib, there is a clear contraindication.
Also.
No. You can give both of them. It's given in Harrison. You can give both of them. Maintenance.
So it's written that bortezomib only you cannot give, and the reason for giving melphalan is something else. Okay, fine, no problem.
Okay, like the patient is not a HSC transplant candidate, so you can give melphalan. Yeah. For the typical appearance, will be. What?
Okay, it's okay. As far as I know, you can check it if you want. If you're going for hematopoietic stem cell transplant, then melphalan is not a choice. Okay, but even if he's not going for hematopoietic stem cell, still the first line is bortezomib, prednisone, and lenalidomide.
Okay, we'll
you can
see
check
that.
if you want.
We'll see that.
Okay, excuse me. Then why did this patient have dysphagia?
I'll explain that actually. I'll explain that. This patient has amyloidosis. So So that will be, this patient had actually cardiac amyloidosis. So that caused compression on the esophagus, and this patient developed progressive dysphagia.
Okay, thanks.
See, that's
Can
all
you
the
tell
primary
which all teams
symptoms.
got
Generally,
the marks and the pounds?
nobody got marks and pounds. Nobody pounds actually.
I
Okay, you got
said,
you pounds, you pounds, yes.
and we gave the full answer also.
Yeah, right. Team A and Team B will, Team A and Team B will be getting full marks.
Team E.
Okay, sorry. Team E and Team B will be getting. You should mention your team name.
My name has Team E.
That I don't know. No.
Sorry. Okay.
Team A will be getting negative.
Sir, could you tell about Team B?
Team B will get full marks.
And E also, right?
Team E will also get. Team E and Team F, Team E and Team B gets 25 points. Team A gets -10, and Team F gets 20 points for the first sub question. Second sub question they are wrong.
So why it can't be Poem syndrome? Polyneuropathy, organomegaly is also there. Endocrinopathy is for the thyroid can enlarge and compress, causing.
How rare it is, How rare it is? It is very rare, no?
Skin changes are there.
Whether it will cause compression. No, this is a case of extramedullary compression. There is spinal tenderness, sir. You tell me whether the spinal tenderness will be there in Poem syndrome.
At least negative can be because it is a close differential. Very close.
No, I can't give. I can't give
First
you.
of all, in Poem syndrome, I think that is monoclonal gammopathy is first associated. It is not a florid presentation of multiple myeloma that is there.
Okay.
And
So we'll go to the
polyneuropathy,
next
I'm seeing any polyneuropathy here. It's an extramedullary compression. For polyneuropathy,
how common is
It does not fit the definition. It does not fit into polyneuropathy. It's actually compression of the spine.
How rare is Poem syndrome and how common is multiple myeloma? You tell me. Okay, next question. We can go to the last case. Team 1 will be getting this case. Team 1, are you ready?
Anantaraman, which teams get the pounds marks? Tell once again, and how much marks?
Pounds marks. Team E, Shagun, and Team B gets full points, 25-25.
B for Bombay.
And this one, Team A, they will get -10. Saravanan wrote poems.
So Team B and Team E get 25 points, and Team A gets -10, right?
-10.
Okay, fine. Continue.
And Team F gets +20, right?
Team F gets +20. First question they got it right. Treatment is wrong.
Okay. Fine. Continue.
So 42-year-old fair complexioned woman working at an NGO comes to a dermatology OPD with complaints of enlarging black mole in the right foot for 6 months. The patient noticed that the mole is present on the dorsum of the right foot for many years and has increased in size and darkened in color over the past 6 months. History of itching around the mole for the last 3 months. No history of a single episode of serious discharge mixed with blood in the past 1 week. When the patient inadvertently applied pressure on the mole. No history of pain or ulceration. History of swellings in the lateral leg for 1 month. Insidious in onset, painless. Brownish discoloration, increasing in size, appears to containing fluid. Not associated fever or trauma. No history of abdominal pain, jaundice or breathlessness, hemoptysis, altered bowel habits, headache or altered behavior. No history of any sunburn or tanning. No history of hypertension, asthma, diabetes. No history of similar complaints in the past or cancer syndromes in the family. Next slide. The patient is alert, oriented, pulse or respiratory rate BP normal. Pallor is present. Right inguinal lymphadenopathy is present. Non-tender, hard and mobile. 2 nodes are present. Skin examination and apparently 5 cm diameter blackish lesion is present on the medial dorsum foot. 4 cm distal to the medial malleolus. It is asymmetrical, having regular borders. Radial spreading with blackish center and brownish peripheries. There is no perilesional inflammation or discharge or crusting or induration or sensory changes. There is a small mole 0.5 cm from the lesion. Distal neurovascular status normal. 3 blackish elevated nodules of 2 into 3 centimeter each with cystic consistency is noted 4 to 5 centimeter away from the lesion, just superior to the medial malleolus. Next slide. Whole body examination, multiple moles observed over the lateral neck, chest wall and forearms. None of them are more than 0.5 mm. No asymmetry or border irregularity or elevation or changes in color. CVS, RS, perabdomen normal. Next slide. That's all. So diagnosis. So the brief. This is a very easy case. So I'll be opening the pounds only for 30 seconds. Teams can pounds. Team A, be ready with your answer. Anyone is pouncing? Actually, it's a very simple case, straightforward case. So okay, if you don't
10
tell the
seconds
stage.
remaining.
So okay. Okay. Team F has pounced. Okay, fine.
Time's up.
Okay, only Team F has pounced. No other teams are pouncing. So Team A, you can tell your answer.
Melanoma. Malignant melanoma.
Okay. Why do you think it is malignant melanoma, and what are the other changes that are seen?
Black more. It is increasing in size. Then lymphatic spread is there. Metastasis.
Fine. Then what are the other satellite lesions are
there?
Okay. Sub questions. We can go to the sub questions. So how will you confirm the diagnosis and what is the treatment for this?
Treatment is ipilimumab and vemurafenib.
What that is the only treatment you will do?
Confirm the treatment is confirm the diagnosis is biopsy. Confirm.
Fine. Then what is the treatment for this condition? Be specific. Be fast.
Chemotherapy. Ipilimumab and vemurafenib. IL-2 agents.
How common are those drugs given? Have you seen anyone giving those drugs? Common things, common, no? Someone else. Only teams. Okay, fine. We'll go for the answer. So this is a malignant superficial spreading melanoma. Malignant melanoma I will accept with both satellite and in-transit nodules. Team F had answered malignant melanoma with satellite nodules. We'll give them points. Team F gets 25 points on pounds. Team A will also be getting 25 points for the correct diagnosis. So biopsy should be taken from the lesion in there is a specific type of biopsy for this melanoma. Actually, you have to be taking it at the thickest area. Even if it is a center, you have to be taking it at the thickest area. This is a complete cylindrical biopsy. You have to extend it up to the subcutaneous tissue. Then only you can grade the depth of the tumor. So second, how will you treat this patient? You have to confirm the lymph node spread with biopsy, rule out metastasis. First, the treatment for the primary lesion is the wide local excision with 2 centimeter margin and total inguinal lymphadenectomy, because in this patient lymph nodes are positive. First, you have to see whether it is reactive or non-metastatic. Then for the in-transit nodules, you will be giving isolated hyperthermic lymph perfusion, IHLP chemotherapy, which is melphalan and IL-2. And we have to see lymphadenectomy findings. If it is positive, then we go for radiotherapy. Okay, Team A, you answered. I can't just accept biopsy. There is a specific thing in this patient, and you didn't answer the treatment part. So you'll be getting only 25 points in this case. So Team F and Team A gets 25 points. I think that's how you can see the scores.
Sir, IL-2 agents told me.
That is not the complete treatment, no. First, you have to treat the primary lesion, then only you will go, no. How can you directly go there?
Okay. Saravanan, listen, for this cancers, no, this chemotherapeutic agents have a survival advantage of extra, I think, 6 months to 9 months. So chemotherapy might seem very fascinating to know all the maps, but you have to know what's the state of art therapy here, right? The treatment should be like wide local excision first should be done. Otherwise, without the removing the primary tumor, how will you go ahead? And also you have to do lymphadenectomy here. And HILP is a specific treatment for this in-transit nodules.
In-transit nodules.
Specific for in-transit nodules, this HILP. Otherwise, you won't do HILP. So
Maybe these people
chemotherapy
are
is
second year, so
adjunct only.
you will learn that. You will learn that. Okay, fine. They'll be getting 25 points, and team F will be getting 25 points and points. I think that's all. This round is over. I'm sorry if there is any mistake or something from my side. Scores.
Yeah, it's being processed.
Oh, fine. Actually, these cases I took it from sub-assistant. Some case surgery cases I took it from sub-assistant. Some cases from up-to-date. So you can go and refer that. All are common cases only. All are surgery cases which you will get in ward, except that LAM. DIPG is common in pediatrics. So 20% of all brain tumors, all pediatric brain tumors is DIPG. Multiple myeloma is another common case. All were typical presentations.
After round 1, the scores were as follows. Team A got 5 points, Team B 2.5 points, Team C 15 points, Team D, Team E got 0, and Team F got 15. In round 2, Team A got 5 points, Team B got 60 points, Team C got 10 points, Team D 0, Team E got 25 points, and Team F got 35 points. In total, Team A is now with 10 points, Team B has 62.5 points, Team C has 25 points, Team D is on 0, Team E has 25 points, and Team F has 50 points.
So is there any disparity with the scores? Any participant? So if it's correct, if the scores are correct, I've been also keeping a tally. It's correct, I think. So we'll move on to the next round. Can you move on to the next round? Oh, hope it wasn't tiring. I think people might. So the third round is the hurricane presentation. Any guesses? Anyone can guess what which tumor typically has this name, the hurricane presentation? Which tumor has this typical name? Anybody?
Choriocarcinoma. Testicular choriocarcinoma.
Okay. Yes. Right. You are right. It can be. It's actually choriocarcinoma, but can be there for seminomas too, because some seminomas, I think 2.5% undergo this phenomenon, hurricane presentation. Within 1 month, they will have florid metastasis, and prognosis is very poor. So this is our, as you can know, this round will be a very faster round. So you'll have to be on your toes. Since we don't have a facility of buzzer on Zoom, something we'll try to simulate an environment like that. So what we'll do, we can move on to the rules now. So the round will have not 15, I'm sorry, it will be 12 images and connections will be there. Each slide will be given 30 seconds, but you can answer before that, because the first one to answer will only get the points. You have to message the answer fully, like whether the diagnosis or the connection, you have to mention it fully. You have to mention the answer fully. For example, if the answer is FAP syndrome, you cannot mention FAP. You have to write the full form, familial adenomatous polyposis syndrome, and try not to make gross spelling mistakes. No extra time will be provided in addition to 30 seconds. And it will be answered to everyone, mind you. It will be answered to everyone on the group. It will be answered to everyone. So the first person to answer will be selected on the basis of how fastly they answer it on the Zoom group, right? If you answer to me privately, then you will say that I am doing partiality. So we want it directly on the group. Mind that. If you answer to me personally, I won't consider that. So each correct answer fetches you 10 marks, and wrong answer will fetch you 5 marks. Suppose there is one answer and the chat. In the group means the chat, in the Zoom chat. Don't type it in the WhatsApp group or something like that. So please type in the Zoom chat box. So each question has 10 marks and wrong answer fetches 5 marks. Suppose if you answer it first and get it wrong, it's 5 marks. Suppose you answer it in the third option, but you are after the other person, even if you are correct or even if you're wrong, you won't be awarded any positive or negative points respectively. So we'll move. So everybody is ready, right? You understood. Any doubts are there? Please clarify it. We'll move on with this round very fast. And you have to come up with the
So only one team will get the first plus 10 correct answer, if or two.
Yes. Listen, the first answer on the Zoom chat box, whichever appears, I'll consider that. And no other answers after that will be considered. No answer, even if it is correct, we won't give him marks. Even if it's wrong, we won't deduct marks.
If the first answer is wrong and the second answer is correct, then
no, he won't get marks, because person, this is like fastest finger first, right? Like we don't have some mechanism. If it had been on offline quiz, on a buzzer kind of. Here, hello, am I audible?
Your voice is breaking down.
Yes. So the fastest person to answer will, his answer will only be considered, nobody else. Because if that person gives a partial answer correct, or if the second answer, if I give them a chance, then it will be like giving some hints to the other people. They can also now take the hints and like message the correct answer. So that there is no point. So the first answer and the fastest answer, I'll consider that. And you have to type it fully, mind you. Whatever questions come, you have to type it. Say there is a connect, and I tell you to explain that. Please explain first image, second image, third image, fourth image. If I don't tell you to explain, please don't explain. Just mention the diagnosis in full. Okay. So am I clear? Only the first answer which appears in the Zoom box, that would be the fastest answer. And please mention your team names correctly, team alphabets correctly. Team E, you had not done that previously, right? So you please write your team alphabet correctly.
Okay.
I urge everybody to do that. Otherwise, it will be very difficult. So everybody has changed their name, right?
Yeah, just to put the team name. We don't even need the name. Just to put team A, B, C, or E, or
Team
F.
alphabet. Yes, yes, yes. So okay, we'll start. We'll start. So teams, please get ready. Next slide. Shagun, please change your team name. Otherwise, so you can move on to the next slide. I'll read the question and then the time will start. Histopathology of a resected accessory nipple or breast specimen showed the following image and was positive for CK7, ER, but negative for HER2 and Ki67. No evidence of ATPI and malignancy. Diagnosis. So I'll accept. So the first answer was. So the first answer was by John Emmanuel, team F. So they will get a negative here. So the diagnosis is not Paget's disease. I mentioned all the points where Paget's disease, it's negative for Ki67, no ATPia or malignancy. So can you move to the answer? It's actually Toker cell hyperplasia. It's very typical in an accessory breast or nipple specimen. So because Toker cell is actually the like precursor for this DCIS type of like lesions like Paget's disease, but this is not Paget's disease. I had mentioned specifically why it's not Paget's disease. So team F gets -5. Team F gets -5. Do you understood the mechanism, right? How the thing works? The first answer. Be ready with your keyboards. One team listen and see the image and other teammate can type it. We'll now move fast. Come on, the next question. Spot diagnosis. Come on. The fastest answer. Okay. We'll give team 5 here. Marks. We'll give 10 marks to team 5.
Team 6, right?
Team F.
Sorry, team F. Team F. I'm sorry. It's team F. So we'll move on to the next question. So please, teams, get ready. So next question. So now diagnosis. This is the history. Come on, fast. Fast. Come on. So yes, I'll accept team E's answer. I can understand the thought behind the spelling. It has been typed in speed, so I can give team E 10 marks here.
Team A.
Wait. Okay. I'm sorry. It's team A. Sorry. And please, from the next time, a bit of correct spelling. I told you.
Can you please check mine? I think mine came before team A. Can you just check once?
No, in our chat, I think team A is showing first.
Team A is first.
Okay.
Everyone, please try to have proper internet connection. Okay, then otherwise you will be missing out unnecessarily.
So be quick with your keyboard, please. So the next question. So buzz. Now spot diagnosis. Come on, guys. I'll give team E, can you explain what is that? I won't accept auto connects. Can you speak up? Your answer got autocorrect, I think.
Yeah. It got auto-corrected actually.
So what's it? Just tell it.
Yeah, it's
I'll give you 2
SYD
seconds.
unused. CIR,
Yes, I'll give you 10
SYD
marks. I'll
unused.
give you 10 marks. Please don't make such gross mistakes. Take 2 extra seconds, and please ensure autocorrect is off in your keyboard. Please ensure that.
Yes, so like if anybody can type anything and say that autocorrects are like.
No, but they told aneurysm is there, right? They were getting the ID part. We can understand
so
that.
a person sent the answer. Team F sent the answer after that.
So from now on, I'll accept only correct answers. Please, everyone, ensure your autocorrects to be off. Please ensure that your autocorrects are off. I'll answer only like full answers and no gross spelling mistakes. If gyratum 1A is missing, it's fine. But if gyratum is only not there, then I won't accept. So everybody's autocorrect is off. Keyboard settings, please. Your autocorrect should be off.
Anirban, one minute, Anirban. Team C and Team E, like your cameras are not focused properly. Team C. Okay, fine.
What's the problem?
You can.
Is it open
now? Okay. No, your teammate had the problem. Like I was not
Actually, I
able
have
to
to
see.
type. That's why the camera is like that. Otherwise, how will I type?
Okay,
so
okay,
you can
okay,
ask
fine.
it.
Same.
Yes, right. It's fine in this round. So please autocorrects off, and I'll answer. If one spelling is only wrong, some other word is there, I can accept if gyratum is GRRTUM, like I won't accept. You have to write gyratum. If only 1 or 2 vowels get displaced, that's fine. But don't make it too gross. Right. So we'll move on to the next question.
Who's awarded the point for
Team
question
D.
number 4?
Team D.
Okay.
So we'll move on to the next question. Now I need the diagnosis and explain the first and fourth image. Please note, explain the first and fourth image. How is it is related to the diagnosis? I need the full answer. No part marking. You'll get negative if you tell. No, Team C gets negative. Team C gets negative. I would accept no other answers. Team C gets negative here. I told diagnosis, please read the question first or hear me first. Diagnosis and explain first and fourth image. I need in one answer, one chat. No different, only in one single text. I need the full answer. If it has to be given. Team C will get -5 here. So we can move to the answer. The diagnosis was correct, but I was wanting the explanation for the first and fourth, how to come to the diagnosis. So the first image is a picture of an award rosé that you get on your sports day and all. You might have wore those things. And the fourth image is a blueberry muffin. You have to mention that diffuse skin metastasis, stage 4S, anything would have been accepted. So go on to the next question. Be ready, teams, and see the question first. Gene mutated in this disease, and apart from melanoma, name one cancer the patient is at risk of.
Ten seconds remaining.
Okay, I can give it. It's not one. It's not 1B, but I can, like, it is partially correct. So I won't deduct a negative, but I'll give you 7.5 here. Definitely. So can we move to the answer? It is actually CDK and 2A. So that's more common, right? And CDK4 is the protein. So, and pancreatic cancer. He was absolutely correct about that. We can excuse this 2A or 1B. That's very confusing for us, and I'll accept that. I'll accept 7.5 marks will be to team C. So can we move to the next question? Please read the question. This is a spot diagnosis. No need to explain. Come on. Come on, guys. What do you see here?
Ten seconds remaining.
So team F will get a negative here. So the answer is banana and Ruvalcaba-Riley syndrome. Cronkite-Canada syndrome is not like this. So
Penile
because you
pigmentation
can
is Cronkite-Canada only.
no, it's also seen in Banana and Ruvalcaba-Riley syndrome.
And in Ruvalcaba, okay, the first image is okay, but fourth, we'll check once, right?
Yes, we'll check. Very characteristic of this Banana and Ruvalcaba and Riley syndrome.
Yeah, macrocephaly is characteristic, but penile pigmentation is Cronkite-Canada. Just
But we want the full
Just
diagnosis. We'll check. We'll provide you the thing. Anantavan, can you check Sabiston the table?
Sure,
with
sure,
inherited syndromes.
Sure.
Team F gets a negative here, -5. So we'll move on to the next question. So find the common link. Please mention the common link between all these four in terms of delayed adverse effect, and mention the odd one out with that respect, with that common link. Teams, please, I need a like two-line answer here. Don't mention it half. What is the common link in terms of delayed adverse effect and odd one out with that respect?
Time's up.
We can give yes. Why?
Hello.
Yes.
In etoposide, the latent period of the AML will be 2 to 3 years, which is less than the other ones, which are 7 to 8 years, and there is no
you're right.
And there is no predisposing myelodysplasia.
Yes, you are right. Very right. You are absolutely correct. Because I told mention the odd one out with that respect. You are correct. I did not expect the full reason, but for academic purposes, I told mention the odd one out with that respect. You are absolutely right. Your reasoning is also right. So you will get team B gets +10. Team B. Please mute your mics otherwise, because this is primarily a round to be written on the chat box. So we'll move on to the next question. Question number 9. So identify the famous groups of drugs and its usage for more than 5 years has been associated with an relative risk of 1.7 to which cancer? You can see 4 images here. You can see 4 images, and that leads to a diagnosis of only one drug.
10 seconds remaining.
One group of drugs. And which cancer, by the way? I need a full answer here.
Time's up.
So team F will get a negative here. So it's angioedema here. We are showing angioedema here. And this is actually an animation of COVID virus. COVID virus. This is bilateral renal artery stenosis and diabetic nephropathy. Anybody wants to connect? Which group of drugs?
ACE inhibitors.
Yes, you're right. And can you tell the cancer to which its RR is increased? It's not that much proven, but few studies from UK and Finland have shown this.
RCC?
No, it's not RCC. It's actually lung cancer. It's a
Okay.
non-squamous, non-small cell type of lung cancer. So anyway, we won't get marks, but the connect was good. So I can yes. So team F will get a negative here. So we will move on to the next image. Please be ready with your thing and think. This is a spot diagnosis. You have to tell me the diagnosis. Yes, I'll give team E marks. I'll give team E marks. 10 marks to team E.
Remaining.
Team E. E for atoposide. I'll give them marks, 10 marks. The answer is right. It's Howell-Evans syndrome or tylosis with esophageal carcinoma. It's an autosomally dominant inheritance is there. So they will get the marks here. So teams, be ready. 2 more questions coming up. Next slide. Come on. Connect and diagnose. I want the diagnosis here from the connection. You can see 4 images here. Connect that. No need of explanation. I don't need the explanation here. Connect the 4 images here. Yes, you are right, team A. You get 10 marks here. You get 10 marks here, team A. Excellent. This was an excellent answer. So we'll move on to team, the last question here. Come on, spot diagnosis, connect. Only one answer I'll accept. No, team E, I'll give, I won't give marks.
Gene, retinoblastoma gene, RB gene.
What?
That's osteosarcoma and that's retinoblastoma. So RB gene.
No. You see the other features, that facial thing. So it's a case of team E gets -5 here. So actually the facial one was the facial the rash or the lesion was very specific. So it's an osteosarcoma, it's a cataract, it's some radius and absence is there or other radial anomalies can be there and a characteristic facial appearance. Can anyone say the diagnosis for academic purposes?
Fanconi syndrome. Sorry, Fanconi anemia.
The facial one is very rare and the cataract, I think it's not that characteristic. So the answer is Rothman-Thompson syndrome. It's very characteristic. Cataract, radius anomalies, facial appearance and a rash and predisposition to osteosarcoma, RB, all those things. It's actually not a defect in RB gene. If you would have told me the gene, it's actually a DNA helicase gene. So which is involved. It's not RB. If you would have told me the gene properly, then I would have considered. So yes, that's my round. My round is over now. So can we come up with the scores now?
So after round 3, the round 3 scores are as follows. Team A has got 20 points. Team B has got 10 points. Team C has got 2.5 points. Team D has got 10 points. Team E has got 5 points. And Team F has got -5. The total stands as follows. Team A has 30. Team B is at 72.5. Team C is at 27.5. Team D at 10. Team E at 30. And Team F at 45.
Okay, so now we'll move on to our next round. So the next round is Royal Connect. It's your quiz, make it large. You can get the maximum number of points apart from the case round, which was a bit more difficult. But this will be a simple round. You have to have some presence of mind to connect 3 given subparts to a common theme. So we'll move on to the rules now. So this is a round where each team will get 3 questions without answers being shown in between. All the 3 answers or topics will narrow down to one common theme. You can attempt to answer the common theme in any 3 subparts. You can attempt them. You won't be deprived of another chance if you get it wrong on the first attempt. But you have to be correct. Or you can be wrong, but I won't be telling you that. If you are correct, then I'll tell you. You are getting 45 at that point, or 30 or 15 respectively. Anyways, after the third, you have to anyway say the common part. I think without 3 parts, obviously you can get, I think, the first part, but let's see if you can guess it very wisely or wildly, you may get a 45 marks there. So for a sub case type sub question, I'll be reading out and you will get exact 45 seconds after that. Mind you, 45 seconds or 1 minute, I'll tell that whether you'll get 1 minute or 40 seconds. Wait one.
Hello.
Yes. You can say whatever you.
So if like after the first question, I suppose I answer it correctly and I attempt the common theme, but the common theme is wrong. So do I get to answer the common theme again after the second subpart?
Yes, you can get. You will get that chance.
So we can answer like after the first question. No, there's no negative or chance.
No. There is no negative in this round. There is no negative. So we finished with team B on the first round, right? So we'll move on to team C. Or in what way would you like me to do this? The highest one first, or the team C first?
No, the team C, the same order.
Okay. We have already attempted, so now it should be from team D, right? Like ABC. Now C has already played, so it should be from team D now.
Yeah, team D.
Okay, so we'll team D. Do you have any problem, or any team who wants to answer it first? It's not like any. I'll tell you one example. Suppose there is a connect of sarcoidosis. You get that correct. Suppose there is a connect of Lyme's disease. You get that wrong. You don't know the answer. And again, there is a case of GBS. You answer. Now, sarcoidosis and GBS, you connect them. You didn't know Lyme's, but the diagnosis here was, the common theme here was bilateral facial nerve palsy. So this goes like this, right? I hope my example was very clear. Here the subparts may not be related to oncology per se. It may be a related condition which might be predisposing, or it might be related to a certain habit of the patient, or it might be related to some staging or drugs which have been used for other things which are predisposing to oncologic reason. So, okay, we'll move on. So, Team D, are you comfortable with answering first? So, okay, I don't get any answer from Team D. So, we'll start from Team D.
My teammate is not able to unmute. Can you please see that?
Team D.
Yes, yes.
So, Team D, I'll read up your questions. I hope you got the rules in this round. So, we'll move on to the first Royal Connect. Team D, it's to Team D. So, can we move on? The first support. A 65-year-old female presented with recent onset of fever, sore throat preceded by severe asthenia and abdominal distension for last 3 months. She had underwent a MRM and underwent chemotherapy for 4 cycles post-surgery 5 years ago. She stopped hormonal therapy due to an osteoporotic fracture 2 years ago and had lost to follow-up. Physical examination now revealed hepatomegaly 2 cm below the costal margin and marked splenomegaly 6 cm below the left costal margin. Laboratory tests revealed a normocytic normochromic anemia with hemoglobin of 6.3 gram% and 0.5% reticulocytes. The WBC was 1200 and platelets were only 22,000. A peripheral blood smear showed marked anisocytosis and poikilocytosis. Many teardrop erythrocytes and normoblasts were seen, and there was a marked shift to left in the granulocytic series. Blood biochemistry revealed altered liver function tests. The RBC utilization was 41.5% on day 12 with a T-half of 34 minutes and a plasma iron turnover of 3.2 milligram Fe. So these findings are consistent with ineffective erythropoiesis. So I've given you the findings on PBS and I want your diagnosis at this point with a given clinical scenario. A complete diagnosis here.
What's the time?
10 marks. So time starts now, 1 minute.
Seconds remaining.
Team D, please come up with an answer. I'll be expecting an answer just after the 1 minute ends. I won't give you any extra hint or extra time. I mentioned all findings with bold points here. I won't give you.
Time's up.
Team D, please come up with an answer and unmute yourself, please.
Next question. Next question.
Team D, please come up with an answer. Otherwise,
we'll go with next sub question.
There is no next sub question. You have to answer. You know this diagnosis or not? I won't tell you the answer, mind you, if you're wrong. If you're correct, I'll tell you correct. Please make it fast. You tell me you know or don't know, or give it a try. I'll give you 10 more seconds.
Chemotherapy related some complications.
No. I can give you that. Chemotherapy related picture is not this. It can. I don't see any MDS picture here. To be frank, no MDS picture here. So okay, I'll move on. Altered liver function test. How will you get altered liver function test after 5 years the patient has stopped chemotherapy? I'll move on to the next sub part. I won't tell you the answers here.
Hello.
Yes. Now connect the 4 images and explain it to me. Your time of 30 seconds starts now.
Ten seconds remain. Time's up.
Carcinoma breast.
How? How? Explain it to me.
Wait, first image is cookie cutter, so I thought non-comido is a
It's not
yes.
cookie cutter. It's not cookie cutter, please. I'll show you an image of cookie cutter.
Okay, then it's no.
Okay, so you don't get it correct. Anyway, these 3 images, I think it was kind of giveaway.
Hello?
Okay. Hello? No, and no one else gets to pass or answer. We won't, because they might tell the common theme afterwards. So you did not get any of the 2 questions correct. We'll move on to the 3rd question. So yes, please see this. You will get this. You will get this correct, I believe, if you read the question properly and the scenario. A previously healthy 19-year-old man presented to the urological emergency services with an history of painful erect penis for 24 hours. There was no history of trauma, malaise, night sweats, joint pain, and cough. No history of sickle cell anemia or toxin intake. The patient gave history of 2 similar previous episodes lasting for few hours and subsiding on its own over the past 1 month. The physical examination revealed that the liver was palpable 1 to 2 centimeters below the right costal margin, and spleen was 3 centimeters below left costal margin. The conjunctiva appeared pale with no jaundice. The penis was erect, firm, and tender with superficial venous engorgement. Lab data showed hemoglobin 9.2 grams per deciliter, hematocrit 25.7%, white blood cell count 296,800, which is quite increased, and platelet again increased 9,36,000 millimeter mercury. So peripheral blood sphere, please see it. So can we move on to the next question? I hope you saw this thing. I hope you saw the image, right? Properly. You see this image. I'll give you 5 seconds to see this image. What is this showing? Just see it. Very characteristic again. A very unique finding of this tumor. Next, I'll move on to the questions now. What is the diagnosis? Name a drug for the management of this condition when this is resistant to both first and second line therapies, TKIs. So I need the full answer here.
What's the time?
The part question. No, the time is 45 seconds. So you can tell it before that also if you know. Why delay?
Seconds remaining.
10 seconds. Come on. Come up with the diagnosis, guys. This one was very easy. WBC, platelets, physical examination, presentation. Time's up. Please come up with a diagnosis and the drug. Team D.
CML.
Yes, the diagnosis is correct here. I can give it to you. And the drug. Please, I'll give you 5 seconds here. time up. I can give you more time. Okay, fine. I'll consider that. And now tell me the common theme. I'll give you 30 seconds. Score a timer. 30 seconds to answer the common theme. If you can, with one diagnosis.
Fifteen seconds remaining. Time's up.
So, okay, they did not come up with a common theme. So, we'll now move on to the answers here. So, the connect here was massive splenomegaly actually. So, if they had got the second one right, still they could have tried. So, it's a case of secondary myelofibrosis due to recurrent and metastatic CA breast. It was a clear history, osteoporotic fracture, the patient discontinued the treatment. There was altered liver function test, which would have been due to metastasis and unlikely because of chemotherapy after 5 years. And there was a clear picture of myelophthisis there. So this is a case of secondary myelofibrosis due to recurrent and metastatic CA breast. And hairy cell leukemia was the second. It was actually the image of a red pulp was given. It was the rat trap. So it was trap, it was MacBook, from that Mac, susceptibility to Mac, and it showed bone marrow fibrosis there, which is typical of this tumor. So, okay, I hope you get the scheme. This one was, if you had got 2 questions, I think you might have got it correct. I hope the next teams will note this and try to answer the pattern. So, we'll move on to team E here. So team
How much marks do they get?
Team D gets only 10 marks for the third part, sorry, only 10 marks here for team D. So we'll move on to the next question. Team E, are you ready? I need a verbal confirmation.
Yeah.
Yes.
So yeah, we'll move on to the next. So a 9-year-old female presented with 2-day history of increasing swelling, erythema, and pain in the flexor tendons of the volar forearm compartment, most marked in the flexor pollicis longus and flexor carpi ulnar radialis. The pain was worsening at rest and increased with either passive or active extension of the wrist or fingers, especially the thumb. Overall, her clinical picture was concerning for an evolving tenosynovitis. On probing, the patient also gave a history of asthenia, recurrent gum bleed, and 1 episode of sore throat treated by antibiotics for 1 month. Axial T2 MRI images demonstrated hyperintense signal of a rounded lesion surrounding the median nerve and lying adjacent to the flexor pollicis longus and flexor carpi radialis muscle. So it's a hyperintense mass lesion. Labs showed a TLC of 18,000, platelets 50,000, and HB of 8, and peripheral smear showed abnormally large cells with nucleoli and granular chromatin, and on flow cytometry, they stained positive for both pus and NSE. Bone marrow aspirations revealed cells with the following immunophenotyping: CD13 positive, CD33 positive, and CD11B positive. What is your diagnosis? And I'll give you 45 seconds for this because I'll mention all the key features in bold. 45 seconds here.
Hello.
20 seconds remaining.
AML, M4 or M5?
One. I need one specific. The certain markers are given. I need the specific answer. Time is up, right? Yes. You come up with an answer. I'll accept a specific answer here. You are close, but you need to choose one number there.
AML M5.
Okay, so I can't give you marks here. It is M4 because it stains both for myelocyte and monocyte lineage. It was very, I told you to see the immunophenotype. Okay, it happens, but you were very close. The presentation is sclerodoma actually here, sclerodoma with some leukemic features. So I'll move on to the next one. So connect these 4 and give me a diagnosis here. You see 4 images here. I don't need explanation. I need a diagnosis here. I'll give you 30 seconds. Timer. It's quite evident. 4 images.
$15 seconds.
Did we have to tell the connect also, like the explain the images also, or just the connect?
No, you can tell me the diagnosis. Time's up. Please come up with an answer.
Pseudomonas, that's ecthyma gangrenosum.
Okay. I'll give you 10 marks here. So next slide. So now read this. I belong
Can
to
we
a...
try the Mega Connect first? Because we get a
Okay,
chance.
you can try. Yes.
Can you
Move
change
on to the
site?
second
Go
question.
back
Move on to the
previous slide.
second question.
Yeah.
Try the Mega Connect. No, I won't give you extra time for this at this time. I can give you extra time at the end of third.
Sweet syndrome.
No, actually, the third image does not explain this thing. We'll move on to the third image.
Okay.
I belong to a class of drugs extracted from sewage outfall of Sardinia coast. Originally extracted. So I act against a superbug that my 3 genera of grandfathers could not target successfully. I have become the first-line drug for treating dangerous cancer-associated infections and gram-negative bacteremia in ICU patients because of widespread resistance to my grandparents. There is one distant relative similar to us structurally who can act in the same way as me against the superbug, but has to be given 4 times daily, whereas I can be given once daily or twice daily. Who am I? And I'll give you 30 seconds.
Is it colistin?
No.
Hello.
It's not. Yes.
15 seconds remaining.
That's not right. I can't give you that. So it was very specific actually. The first thing was specific. A class of drugs which was originally extracted from sewage outfall of Sardinia coast. So I'll move on to the answers. Would you like to wait? Would you like to answer the Mega Connect? From this, just add this these 3 things. This you have 30 seconds for the Mega Connect now. Just Mega Connect 30 seconds. Add these 3 or 2 which you have got. Here it's actually an additive finding rather than a common finding.
5 seconds remaining. Time's up.
Do you want to try?
No. Answer the Khado.
So we'll see the answers here. So basically, the first answer was AML M4, which presented as a sclerodoma, and the second answer was correct. It was ecthyma gangrenosum, and it's cefepime, a 4th generation cephalosporin. I mentioned 3 generations failed because the pseudomonas and the gram-negative bacteria which are resistant are generally like susceptible to cefepime, and this is a 4th generation. I mentioned 3 generations failed, and the common thing or the connect here is febrile neutropenia due to AML or its treatment. Most commonly it's caused by Pseudomonas, and that's why we often give it as an empiric treatment, because it's an oncological emergency and often beds are not available in our wards. So maybe we have to keep them in the like waiting room or so. So we have to give them a drug empirically for which can work over 24 hours, and so that the infection can be cured. So that was the reason of putting this whole sequence of thing, because febrile neutropenia is the most common oncological emergency. So we'll move on to the next. Well done. You almost went away with the 20 points, but if you had got cefepime, you would have gone more. So we'll move on to the team E. Team F here now with the Royal Connect 3. Team F, are you ready?
Yes, we are ready.
So we'll move on to the first question. So, okay. Now connect these images. I'll give you 30 seconds now.
Fifteen seconds remaining.
This is a case of arsenic poisoning.
Okay, I'll give it to you. Do you wanna say the Mega Connect?
1 second. The Mega Connect is
1 minute. என்ன சொல்ல போறீங்க? Hello. Lung cancer is the Mega Connect.
No. You have to see the 2 images. So, next image.
Anirban, just wait 1 minute.
No, only one option, only one thing in yeah.
You can't. Like there's connection issue. Just we will rectify it and come.
Okay.
Yeah.
Anirban, what is the approximate time it will take for the quiz now to finish?
I think the last round is next. This is the second last round, so there will be 5 rounds, right? Rapid fire. We'll wrap it up.
Okay. Thank you.
Next question, though. We'll go to next question.
We'll move on to the next question. So again, 2 images you have to connect and tell me one thing and how does it predispose to the first condition. A brief explanation I need.
30 seconds, right?
30 seconds. Here, 30 seconds. 2 images.
This is esophageal cancer due to Kangri pot.
Seconds remaining.
Kangri pot.
Something like this.
Something like odd tea or something. Consumption with odd tea or something. Hello? Hot tea or hot liquids. Can you hear me?
Not hot. No. I can't consider that. So I won't tell you the answer right now. So you note the crux of the theme. That much you can do. And would you like to try the Mega Connect now? I'll give you 10 seconds. Otherwise, we'll move on.
All are environmental risk factors for cancer.
No. That is very now. This is becoming very generic. You can say smoking is a risk factor for these 3 cancers, or every cancer. No. I'll accept this answer. You answer it in the next round, in the next part. I'll accept only one answer now. We'll move on to the third question. So connect these 3 images. 4 images, I'm sorry, and 30 seconds here. 30 seconds. And you have to give me the Mega Connect in another 30 seconds after you tell me the answer.
15 seconds remain.
சொல்லட்டுமா bladder cancer cystosoma hematobium cystosoma manson இது urinary bladder cancer
Okay,
due to cystosoma hematobium
you have to tell me the no what is the connect here? What is the connect here? I don't want connect here.
Like what do you want, like connect of all this lead pipe colon all that lead pipes and
not yes
அந்த மாதிரி தான் எனக்கு வந்து
right only okay
என்ன சொல்லிட்டோம் ஜான் pipe this all is cystosomia
okay I'll accept it yes I accept it. I'll accept cystosoma. Okay, fine. Now give me the mega connect of all those three. You're right, they are risk factors, but I'll give you 30 more seconds. Risk factors for what?
All are risk factors for sir urinary bladder cancer சொல்றோமா
Specific.
arsenic on the urinary bladder. அவன் என்ன சொன்னா
15 seconds remaining.
arsenic வந்து arsenic risk factors for what ன்னு தான் கேட்டான்.
Time's up.
Hello. Everything
all causes
Yes, you will get 15 points here. Yes, you will get 15 points. Very good. You will get 15 points. That's the connect. So team F gets 2 plus 10 and 1 plus 15 here. So total of 35 points, if I am right.
Yes.
So we'll move on to this thing. Answer slide. So yes, it was the image shown was the character like the specific vessel in which this fermented milk. It's actually a fermented milk. If you would have told me some fermented thing, I would have accepted. It's actually called MURSIC, and its role in carcinogenesis is squamous cell esophagus. It's actually in the middle third part. It's endemic to African tribes. It is because of the fermented milk gets converted to acetaldehyde in the esophagus and not in any other place. So if you would have told me any other answer, I would not have accepted that. So okay, and squamous cell carcinoma, all these three things are predisposition for squamous cell carcinoma at different areas. Arsenic on skin, lung, it can happen anywhere, more so in skin and lungs. MURSIC is for squamous cell carcinoma esophagus, and schistosomiasis is for squamous cell carcinoma in the bladder. It's more commoner than transitional cell variety when it is caused due to schistosomiasis. So we'll move on to the next one. So we'll move on. Team A, are you ready?
Yes, ready.
So yes, we'll now move on with your questions. Come on, team. I'll need the first one. So X is a metastatic presentation of a distant GIT neoplasm. It was also previously called as fibrosarcoma ovary mucocellular array. Y is a type of breast carcinoma that has predilection to produce bilateral ill-defined masses, and hence often it is undiagnosed or presents with metastasis and more frequently produces X than the other types of CA breast. What is X and Y? And I'll give you 30 seconds here.
$15 seconds remain.
X is Krukenberg's tumor.
Why?
Your mic is muted.
Whether it's adenocarcinoma.
No. That's very vague. That's very vague. I won't accept.
Invasive ductal carcinoma.
No. I will accept only one now. I'll move on to the next. I'll tell you X is correct. So you can get 5 here. I won't tell you what is Y. I won't tell what is wrong. So we'll move on to the next. So connect these 4 images. You see 4 images here. Characteristic. And you tell me a diagnosis here. Connect these 4 images. And I want it specifically.
15 seconds remain.
Okay, linitis plastica, gastric carcinoma.
What type it is?
Time's up.
What type?
Diffuse type gastric carcinoma.
Okay, I'll accept that answer. So you will get 10 points here. You go to the next question.
1 minute, sir. 1 minute. Got disconnected.
Okay, okay, wait. You want to try for the Mega Connect? You tell an answer here, right? I can't give you extra time again. You tell me if you want, or I'll move on to the next question.
Is it that peritoneal seeding type of metastasis?
No, peritoneal seeding can be seen in diffuse intestinal type also. So no, I won't accept any other further answer. I'll move to a third one. So dash decreases the abundance of death receptor inhibiting protein flip, thereby reducing the resistance of malignant cells to a process called dash, resulting in reduced circulating tumor cell population and reduced incidence of metastasis due to reduced epithelial mesenchymal transition. So you have to name what is dash. It is related to some management. And what is this process dash? Second part. I'll give you 30 seconds now. These are filling the blanks. I'll give you 30 seconds.
Seconds remaining.
Whether it's some viruses and all produce flip to prevent it from getting death, for preventing from dying. Process is called apoptosis. Then I think BID decreases the abundance of death receptor. BID or fast mediated ligand.
So apoptosis decreases epithelial mesenchymal transition.
Process is apoptosis. Process called apoptosis. The first
process is apoptosis. So what is you connect those two? No, it's apoptosis can occur in so varied number of situations. Even some nuclear damage can cause apoptosis. What is this specific thing? Resistance of. Okay. I'll accept half of this answer, and you can take. Can you tell that specific this thing? First, it's a specific drug name. I'll give you 5 seconds. If you know, you know.
Whether trail.
No. Now I'll give you 30 seconds for you to connect all those 3 schemes. Connect them. What comes to your mind? What common things comes to your mind?
$15 seconds remaining.
15 seconds. Come on, guys, be fast. This one was easier, I think. I've given you 3 to 4 tumors to connect to one thing.
Time's up.
You come with an answer now. Hello, team A, come up with an answer, quick.
carcinomas are diagnosed with cytokeratin 7 and 20 diagnostic markers.
No, that is for type 1 CK20, but that does not explain the third thing, no? Anoikis and that drug, whichever you could not answer, that does not explain.
Yes, sir.
So we'll move on to the common theme now. You got many sub questions right, so you will be getting quite a few points. So we'll move on to the sub part here. So one of our team members, I did not show him the slides, but he still answered me personally. So I thought it was easy because 2 people answered that to me personally without knowing that connect. So we'll move on to the answer slide first. So yes, X was Krukenbach's tumor and Y was invasive lobular breast cancer carcinoma. And you were right, it's signet cell adenocarcinoma or type 2 gastric carcinoma or linitis plastica, and the process was anoikis. It is specific because there has to be anoikis, other resistance to anoikis, otherwise you won't undergo an epithelial mesenchymal transition here. And the drug is specific, anisomycin. So okay, and the connect is E-cadherin. All these tumors and this process involves only one core thing, that's E-cadherin. Even if you would have told me CDH1 or E-cadherin or anything related to APC, I would have accepted. Still, I would have accepted. Right? This was very, very, I think it was easier compared to others. So now we'll move on to Team B. Team B, are you ready?
Yeah.
Have you got the mojo of this round?
Yes.
So yes, I would expect you to come up with a similar, this time a correct one. So we'll move on to the first subpart. I'll read. So connect these 4 things. These are 4 images and come up with a diagnosis. And I'll give you 30 seconds.
Von Hippel-Lindau syndrome, VHL.
Okay, I'll give you 10
10
marks.
seconds remaining.
I'll give you 10 marks. Move on to the next question. So a 20-year-old Caucasian male was diagnosed with early age onset polycythemia at the age of 2 when he presented with hemoglobin of 22 grams per deciliter. The patient was managed with recurrent red cell apheresis. Polycythemia was managed with recurrent phlebotomies. Genetic mutations for JAK2 and VHL germline mutations were negative. At the age of 15, an ophthalmic examination revealed right optic disc edema with decreased vision in the right eye, which further progressed to bilateral fibrovascular membrane formation overlying the optic nerve. A brain magnetic resonance imaging showed protrusion of right optic nerve head into the posterior aspect of right globe with tortuosity of both optic nerves, but no obvious cause of these findings were found. Also, at that time, the patient was admitted to the intensive care unit with an episode of hypertensive crisis with blood pressure more than 210 per 120. Blood testing revealed markedly elevated plasma metanephrines and chromogranin A. Next page. An abdominal CT scan demonstrated a 4.6 centimeter left suprarenal mass and a 2.7 centimeter mass in the organ of Zuckerkandl. The patient underwent laparoscopic left adrenalectomy and resection of the pelvic mass. Histopathology confirmed the diagnosis of left adrenal pheochromocytoma with microvascular invasion with the tumor capsule and paraganglioma in the organ of Zuckerkandl. At the age of 19, the patient was found to have steatorrhea for 9 months and impaired glucose tolerance for 4 months. Then on following up imaging studies, he was found to have a duodenal lesion on 18F DOPA imaging. The patient underwent esophagogastroduodenoscopy, that is UGIE, showing a mucosal covered nodule in the duodenum in the fold immediately proximal to the ampulla of Vetter. Somatostatin levels were elevated The patient underwent exploratory laparotomy for dissection of the duodenal mass. HP of the mass confirmed a well-differentiated neuroendocrine tumor staining positive for somatostatin. I have given you all possible findings and what is your diagnosis. I need a diagnosis and your time is only 45 seconds here. I've read the full case scenario with you.
Is it a polycythemia, paraganglioma, somatostatinoma syndrome? That some syndrome is there.
20 seconds remaining.
I can give you half points for that, but you have to tell me the name.
अरे यार name exact भूल रहा हूँ मैं. polycythemia magnus. F dopa होता है उसमें भी यार fuck.
10 seconds, I think.
I can't remember the exact name.
Okay, fine. I'll give you 5 points here.
Time's up.
Time's up. So we'll move on to the third question. Although I am a FDA approved drug for...
Can you attempt the mega connect?
Okay, you can say. Okay, you can say. Please move on to the previous slide. Yes, tell. No, I won't give you extra time. You have to tell if you know. You can't discuss. I did not allow much discussion.
HIF1 alpha?
That's not the full. It's not 1 alpha. No, it's not
like
1
hydroxylase.
No. I'll move on to the third question. I need a full diagnosis. Maybe the third connect will prove you the full thing. It's a generic again. Don't specify. If you think again specifying will fetch you a common theme, then I think you need to reconsider. So move on to the third question. Although I am FDA approved drug for metastatic colorectal, renal, and relapsed resistant ovarian carcinoma, I often do not find use in the treatment of this setting due to high cost and modest improvement in survival. I love to deprive the tumors of what they love the most. Still, I can help, but the patient develops spiking BP and is at risk for thromboembolic phenomenon because of me. Some patients could not tolerate and develop spontaneous perforation of gut, and some developed nephropathy. However, in topical form, I have found great use in the field of ophthalmology, although I do not know why FDA does not still approve me for these indications. Who am I? And name any of one of my ophthalmic indications.
What's the time?
30 seconds here.
Fifteen seconds remain.
Bevacizumab.
Yes, you are right. And second part?
Proliferative diabetic retinopathy.
Or wet ARMD if surgically not possible.
Okay, fine. I'll give you 10 marks and tell me the mega connect within 30 seconds. I need full. I don't need a half. I need one full common theme which relates all these three things.
हाँ होता है.
मैं बोलता हूँ. Vascular endothelial growth factor VEGF.
So how is it related to the first two tumors?
10 seconds remaining.
One.
HIF1 alpha will be activated, so there will be more of VEGF secretion.
Okay, I'll give you 15 marks here. You could have answered. I wanted HIF VEGF pathway that was more generic. In fact, this syndrome, this I'll move on to the answers. I'll explain you within some seconds. I'll give you 15 marks here.
So how much did we get in total?
I think you got 10, 5, 10, 15.
40.
Yes. Move on to the next one. So yes, the answer is HIF VEGF pathway. Von Hippel-Lindau disease is actually due to mutation, loss of function, mutation of VHL, which is involved in downregulating this HIF VEGF pathway, HIF-1 alpha pathway specifically. But Passage-Juan syndrome is that thing you mentioned. I'll give you 5 points for that. But this is a new change in the recent edition of Robbins. So I wanted the full answer. So this is due to a mutation in EPAS1, or it is also called as HIF-2 alpha. So it's actually the same mechanism, but the pathways are a little different. It's also related to VEGF, but the transcription factors and all are a bit different. So I wanted the HIF VEGF pathway. That's why I did not want it specific. And again, 3 is bevacizumab. So yes, you will get marks here. So can we move on to the next part?
Yeah, ready.
Yes, team C is ready. So we'll move on with the first question. A 30-year-old female came for routine screening and was found to be positive for HPV, and pap smear showed grade 3 CIN. You took the decision to do colposcopy, and she's found to have a small non-bleeding erosion 1 centimeter lateral to os and measure 7 millimeter. Further cone biopsy revealed an invasive carcinoma with depth 4 millimeter. Rectovaginal examination reveals no parametrial involvement. Her index is P1L1. She wishes to preserve fertility. What is the most appropriate management in this case? If you know the stage, you know the management. I'll give you 45 seconds here.
Twenty seconds remaining.
कोनाइजेशन 1A1 में करते हैं, बोल सकते हैं.
Conization. Hello.
Time's up.
I think it's not. It's the what is the stage?
Organization has already been done, right?
1A2.
So what is the management now?
Leap.
Type 1 hysterectomy for 1A2, but she wishes to preserve her fertility.
No. That is for 1A1. The stage is only wrong. So we'll move on to the next question. So you note the what presentation in 1 was there. So you may need to have connect all those 3. You note what case or what thing came. You may need to connect all those 3. So now I'll read out the second question. So a 67-year-old white woman presented with a 3-day history of headache, severe imbalance and instability, nausea and binocular double vision limiting her mobility. 2 weeks earlier, she had a fever, dizziness, cough, which resolved on its own. Neurological examination revealed intact language and cognition, significant bilateral diplopia and nystagmus worse to the right, bilateral dysmetria worse on the left, and broad-based gait ataxia. No focal weakness or change in the muscle tone was noted. Deep tendon reflexes were brisk at all sides, and the plantar reflexes were downgoing on the right and upgoing on the left. She was a teetotaler and was nulliparous. She had a history of endometrial hyperplasia 17 years ago, which was treated with oral progesterone till she attained menarche at 54. She currently is on antihypertensive thiazides. Her gynecological and breast examination is unremarkable. Transvaginal sonography did not show any endometrial thickening or adnexal mass. However, she describes she had missed her routine mammography screening for 5 years. Mammography showed irregular calcifications with speculations. What is your diagnosis? Please be specific. And which cells in cerebellum are the most affected in this disease?
What's the time?
This is 1 minute. This is a case, full case. I'll give them 1 minute because they have 2 subparts also.
Seconds remaining.
The diagnosis is paraneoplastic cerebralitis due to the breast malignancy, most likely maybe due to anti-Re antibody.
Okay.
And the cells affected are
Time's up.
Purkinje cells.
Okay, I'll give you. Third one.
And the mega connect.
Okay, tell the mega connect.
This appears to be like a sequence, like in first case of cervical cancer, that is a gynecological malignancy leading to a paraneoplastic cerebralitis. So, like it appears to be a sequence. Okay.
No. You went in a like you are thinking correct, but it's not something related to paraneoplastic. But you have to connect what is common to these cancers. So you will move on to the third one. So connect this 4 images. I'll give you 45 seconds here because this is a little tricky. I'll give you 45 seconds here. Things are not, you have to decipher them. I'll give you 45 seconds here.
$20 seconds remaining.
See the image, see the third image, see the second image. First image shows some pathway, some proteins. And the fourth image is something like a quadrangular or things like a square or something like that.
Time's up.
Come up with an answer.
HPV.
HPV, but what other three images?
That one is Mike Tyson. This is a polygon. I'm not sure about the third image.
Connect those two, no?
टाइसन को कुछ था क्या उसको माइक टाइसन को?
Okay. So I can tell you both. You have to connect these three. All these three are malignancies.
Okay.
I'll give you 30
seconds. How much
seconds
time
now.
do we have?
30 seconds.
$15 seconds remaining.
Is it some cancer syndrome like HNPCC?
No. CS cervix is
Time's
not
up.
related to to any syndromes. So I'll tell you the connect. This was actually a CA penis. You can see HPV, Mike Tyson. So Tyson glands produces smegma, and that is the most important carcinogen for CA penis, and that is an penile implant, and that is quadrangle, a Dressler's quadrangle, the boundary in which you do inguinal lymphadenectomy in this cancer, CA penis. So that's how. And the mega connect here, the royal connect here. Please move on. Something common to the management here was that sentinel lymph node biopsy has been described for all these three tumors. Although we don't do for CA penis and CA cervix right now, but they were done because no like efficacy or sensitivity was found over to routine imaging, but before imaging and all were discovered, this was routinely followed for cervix, for CA penis. It was definitely followed, and it's being followed still now for CA breast. So that is our royal connect here. So can we move on to the answer slide briefly? So team C get only 10 marks here, I think. We get only 10 marks here. So the staging was 1A2 here actually. It was more than 5 millimeter, right? It was 7 millimeter. So you won't get that points there. You won't get that points. Sorry, it was more than 2 to 5. It was between 2 to 5. So that's why it's 1A2. If it had been 1A1, then only conization would have been sufficient. You would not have needed to treat it earlier. But now you have to go for radical trachelectomy, and you have to cover the pelvic lymph nodes also here, right? So that's where these three things. And now we'll move on to scores. Now I think the round is over. I need the scores at the end of this round.
We will declare the scores at the end. Let's finish with the rapid fire.
Okay, we'll finish with the rapid fire. So this is the round which Soumyajyoti Rao will take. Continued.
So next slide. Go to the instruction slide. So I'll finish it fast. Within 10 we'll try to finish up. So each set has 10 questions. The total time allotted to you is 1 minute. So what I'll display all the questions at once. I will not read the questions. All the 10 questions will be displayed to you all together at the beginning. Once the questions are displayed, your timing will start and you will get 1 minute total. Now you two have to, out of your 2 members, you have to select one person. Only he should answer, he or she should answer. Nobody else, like the other team members, should not answer. Only one person should answer. And the answers should be clear. No ambiguity should be there. The first answer I will accept, and any other answers after that I'm not accepting. Now you can attempt the questions in any order, but mention the question number properly, like question 7, this answer, question 5, this answer. Only one attempt, be loud and clear. One person should be answering. And what else? Yeah, and since you can guess that monoclonal antibodies will be one of the questions in rapid fire. So whenever there is I'm asking that what is this monoclonal antibody, I expect like anti what you have to say. And don't like tell the family of monoclonal antibodies in that. For example, if a tyrosine kinase inhibitor is asked, don't say these are tyrosine kinase inhibitors. Tell us if it's something significant, please mention that. So I think it's clear.
If one team member does not know the answer, like can he take the other team member's name and he answer in his place at that time?
But only one person should
only
answer.
One answer would be given. Yes, only one.
There should not be any double answer.
Yeah, okay.
And if I am not able to understand, like if both of you tell at the same time, I'm not able to understand, and then that particular thing I'm not considering. There is no negative, plus 10 and 0. So are we good? So we'll be starting with, I think, team E first. Okay. So next slide. Team E, are you ready? Wait, don't move. Shubhabrata. Shubhabrata, are you ready with the timer?
I'm ready.
Yeah, okay. So team E, your big Shagun, can you please just speak a little louder because it's little. Just are you ready? Yeah, fine.
Are you able to
So
hear
1
me?
minute, right?
It's 1 minute, yeah. You tell when there is 10 seconds left, you tell once. Before that, you don't tell anything.
Okay, fine.
Okay, so team, next slide. Your time starts now.
Bleomycin, etoposide, erythromycin, carbohydrate. Second false.
Yeah, correct.
Three menin.
No, wrong.
Oh, क्या वो वर्मर होता है? हाँ, sorry. Pyeloneoplastic hypoglycemia and fibrosarcoma, Doge pot syndrome.
Yeah, correct.
ipsilateral, non positive extranodal is N3B stage.
Yeah, correct.
Fifth question.
15 seconds remaining.
Tell the
Indian file
question
pattern
number,
sixth.
please.
Sixth is Indian.
Correct.
Sixth is
Go on,
Indian file pattern.
Correct. Go on.
Selected tumor marker for non-mucinous is seventh is CA125.
Time's up.
Ninth is false.
Okay.
Ninth is false.
Okay, plus that much. So 1, 2, 3, 4, 5, 6. You get 6 correct. So plus 60. 1, 2, 3, 4, 5, 6. Yeah, plus 60. Next slide. Next slide. So this is the answer. I'm not reading out the answer now. Next slide. You post the answer. Yeah, I'm not reading out. I will share the PPT later. Next set. Team F. Are you ready? Team F.
Yes, we are ready.
Okay. So, Shubhabrat, are you ready?
Yeah.
Yeah. So, next slide. Your time starts now.
2 bleomycin. 3.
Correct.
4 is true.
4 is okay. True. Correct.
True. 6 is 5 salliferous cells. 7 is 8 is BRAF inhibitor.
Correct.
10 is
Fifth is
giant cell tumor.
T2 N0 M0.
Wait. One of you.
Fifth one is T2
10 is
T2 N0 M0.
Okay. Correct.
10 is a giant cell tumor of.
No, wrong.
10 is adamantinoma and
no, wrong. You have gone. The chance is gone. 10 chance is gone.
Neurotensin. 7 is neurotensin. Vermofinib is a BRAF inhibitor.
Yeah, that is told. You have 1, 3, and 9 left.
1 is response to chemotherapy in solid tumors.
Time's up.
Tell the proper thing. Okay, so that's not fully
response
correct.
to chemotherapy in solid tumors.
Response evaluation criteria in solid tumor. Okay, so you get 1, 2, 3, 4, 5, 6.
correct. Hyperparathyroidism solliya?
No, you didn't say that. 6 correct, so 60 points. Just a second. And once again, I'll tell you, one of you don't mix up the answer. Like in this question 10, there was a mismatch. You knew the answer, but there was a mismatch. So go to the answer slide. Next. Wait. So this is the answer. We'll go to set 3. Set 3 is for Team A.
Ready.
Team A, are you ready?
Ready.
Okay. Next slide, your time starts.
Yes.
Now.
Capacity bin. Second one is capacity bin.
Okay. Correct.
Genus. Third one is genus.
Correct. Go on.
Then PTH receptor mutation. Fourth one is PTH receptor mutation. Then
no, false.
Then PTH RP. Fourth one.
No, you're gone. You're gone. Not that. Next, you attend the
eighth one
ones.
anti-PDL one.
Yeah, correct.
Then sixth one false.
Sixth one?
False.
Correct.
10th is Ewing sarcoma.
7th one is Ewing sarcoma. No, false. Correct.
7th is
incorrect.
true. 7th is true.
7 is also incorrect.
Time's up.
Okay, time's up. So you get question number 2, 3, 6, and 8 correct. So 40 points. 40 marks. 1 second, just a second. Team B, set 4. Go to the answer slide, Shubham. This is the answer slide, and we'll go to set 4. Set 4. Team B, are you ready? Team B.
Yes, we are ready.
Okay, so your time starts. Shubham, change the slide. Time starts now.
Radiation recall. वर्मर में प्रोटीन
Tell
3
the
is
question
menin.
number.
3 is menin.
Correct. Correct.
8 is anti-CD52.
Correct.
6th is Sézary syndrome.
6th is okay.
एक और मानव बोल. 2 is doxorubicin.
2 is okay. Correct.
क्या
20 seconds remaining.
10th is the DLBCL.
Tell the properly. It's not like tell it properly, fully.
Small cell lymphocytic diffuse large B cell lymphoma, 10th. And 4th is true.
4th is
true. 4th is true.
False. Incorrect. Incorrect.
And 9th is true.
Bus, I can take up to that. 9 is actually also false, so it's gone. So 10, I don't think I can give you full 10. I'll give you plus 5 for that. So 1,
Okay.
2, 3, 4, 40, 45 I'll give you.
Yes.
Okay. Set 5 to team C, right? C. Team C.
Yeah, ready.
Okay. So wait. Next slide. Your time starts. Time starts now.
Cancer liver Italian program. True.
तेरी आवाज नहीं आ रही तो म्यूट पे है वाला.
Which who is answering? It's not audible.
Balaji.
नहीं आ रही तेरी आवाज. अनम्यूट तो कर अपने आप को.
Cancer liver Italian program through WT2 gene.
No, false. Who is?
4th Armaan.
Ovarian cancer.
One of you answer, man. This is very. I can't hear only. 4th is?
Ovarian cancer.
5th is pass. 6th is spider cell. 7th is calcitonin. Olaparib PARP inhibitor. Hartley-Daniel is
20 seconds remaining.
Hartley-Daniel for thyroid surgery. Lateral thyroid surgery. Follicular 1418 IGH2 translocation. BCL2 IGH translocation.
Okay. So you're left with 2, 3, 5.
Time's
Question
up.
1 is wrong.
2 is true. Breakthrough syndrome WT2 gene.
Time up, guys. Time up.
I think
See, this is what I said.
It's I heard them answer it true at the first only, so we can consider 2.
Okay.
Yeah, we had answered it earlier.
Because
only.
see, both of you, it was echoing in the mic, like it was coming through the mobile phone. I think
someone's phone speaker was on.
So it's very, very not possible to understand the voices. So 1, 2, 3, 4, 5, 6 correct, I think so. 60.
Which questions you didn't consider?
1 and 4. 4 you said.
He answered 1.
1 what you said?
Cancer liver Italian program.
Okay.
They answered.
Okay. Yeah. Okay.
And please, which other
then it's
question?
correct. You didn't attempt 3 and 5.
He said 3 for
We said
WT2.
WT2 gene, Wilms tumor 2
बार
gene.
बोला, yes, he said
Not.
twice.
That's what I said. No, it's not audible. Was it audible to
I
others?
told 2 times.
Yeah, it was
WT2
audible.
gene.
You can
Yes,
consider.
I think they told.
Okay,
They did not tell.
We can consider.
Fine. Okay, then I'll consider.
And with
5,
other questions, 5 and
5 you didn't say, and 4 I
5,
think you
yes,
said
yes.
ovarian,
Yeah, 4
yes,
we said
for
ovarian.
bronchial and breast. So
Even
then
ovarian,
ovarian
there is
tumor is most common
paraneoplastic.
association with
Yeah,
paraneoplastic
yeah,
dermatomyositis.
we'll just check it. My reference are from Robbins, so I don't know.
Like we have told in
okay, I'll
classes
check
that
once.
most common tumor. Yes, please.
I'll just check once.
How-
So till
how
now your
many
score
did
is
we got
80.
correct? Okay.
80, and that one we'll check once. So Anantraman, can you just check that once?
Yeah, sure. Da.
Question number 4, paraneoplastic dermatomyositis. So last is team D. Next slide. Go to set 6. Set 6. Okay, wait. Team D, are you ready?
Yes.
So next slide, your time starts now. Tell the question number. Answer. One of you answer because it gets very. It's not possible to understand.
Seventh one false.
Correct.
On 10th one, translocation 11, 14.
No, false.
Fourth one, PTHRP secretion.
Correct. Go on.
Second
You answered
one is
4,
true.
7, and 10. Second one is true, correct?
Time's up.
So you get 3 correct, 1
Posterior
incorrect.
post
So total 30.
anomalies.
No. It's time up. Plus 30. Plus 30 to team D. So I'll just repeat the scores. You just scorers just. Okay. Anantraman, can you just tell that? Do you see it? Or
yeah, I think we can give them.
Okay, we'll give it then. So plus 90, we'll give it. So team A gets plus 40, team B gets plus 45, team C gets plus 90, team D gets plus 30, and team E and F gets plus 60. 60. Fine?
Yes, fine.
Okay. Thank you. We'll just take some few more minutes. We'll announce the results and then we'll be. It's already quite late. We'll announce the result shortly.
So I hope this wasn't that tiring a quiz as compared to whatever knowledge we all gained in terms of organizing this quiz and the participants. I hope you like this quiz as a whole. So it was primarily a charity quiz we had organized. We spent so much of our time so that we could contribute some of our energy towards a better cause. And I thank all of you, each one of you, who attended this quiz and made it a success. And all the finalists, we could go live with such a brilliant team of finalists. The 6 teams, all 6 teams have been great and they have been providing wonderful answers. Even till the last rapid fire round, the scores were so close. We'll announce the score shortly, and I would like some verbal feedback from each of the teams. I would be it's my privilege that top 6 teams from all over the nation, except for East, I think representation from all parts of the country is there. So I would like one word each from each team about the quiz which happened, the prelims and the finals. So can we start with team A here?
Yeah, hello. Hello.
Yes, Bikash. Tell
Yes,
that.
this was a very interesting quiz actually. Like considering my studying in second year, I didn't hope to I didn't hope to come to the finals, but still I managed to come to the finals. That was very great thing. And considering the type of the questions and the cases, it was really nice organizing. Mainly that reasoning part was wonderful. That's all.
Team B, the team from Seth GS.
Yeah, so it was a like what to say, no words for this quiz. Such a brilliant organized quiz. Like the questions were of another level. Such great knowledge, such great information. But yeah, it was a bit tiring, like 3.5 to 4 hours, but it was completely worth it. The amount of knowledge which we got, especially the hygienic vein dissection thing of whole surgery and medicine. So overall, a fantabulous job for the organizing team. Looking forward for many great such quizzes ahead.
Thank you. Team C, team from MAMC Delhi. I told them at the wee hours before the registration closed, and they
Yeah,
even.
thank you, Nirvan. You messaged us personally, and that's
No, I
why
should
we
thank
are
you.
able
I
to
should thank you
participate.
people, because you are. We know you are so great quizzers, and you participated, and it's a privilege
The
that.
quiz was quite good because oncology from all subjects were combined into one place. That's why it was quite a fun to learn, because onco is such a great subject. Thank you, and looking forward to more such quizzes, integrated quizzes. Thank you.
Okay. We move on to team D, team from ESI Chennai.
Hello. Yeah, it was a very different experience to have all the different aspects of oncology pertaining to different subjects accumulated in a particular quiz. And the questions were very standard and very conceptual too. It was a different experience for us. Thank you.
So team E, Shagun and Ibrahim.
Yeah, I really love the quiz in terms of how comprehensive it was, both in terms of depth and reach. I think it covered a lot of topics in great detail, and also a very good approach to certain topics which I never had before. So I'm really amazed.
Okay, thank you. Team F.
Yeah, Anirban, it was a very amazing event. The standard of questions tell the amount of effort you have put in. Like it must have taken a really long time, and it's a nice effort on your part. You and Anantharaman.
Yes, sir. Not only I and Anantharaman, but I would like to thank
Yeah,
all of the
sure.
2K16 batchmates of mine. I want to name them with their contributions that they have put in. Anantharaman helped me in the case round, and it was fantastic. The way he put up case round, the way he found out all the management options. It was fantastic to put such. It is very difficult to make a case of your own and just put it. So I must thank him for helping me in this case round. Even he had labor room today, and he managed to milk out some time for us, and he attended after a 12-hour posting. I sincerely respect his dedication towards this quiz, and he did not have anything to win or lose here, but he contributed his best. And I would like to thank Soumya Jyoti Raha. Shomo helped me from the the dawn of this quiz. It was my brainchild, but without Shomo's help, it would never have materialized. It would have stayed a dream. It would have stayed a dream to contribute such an amount in thousands to this children in need. So I really thank Shomo Jyoti, starting from registration, starting from the basic thing, the trial run, the quiz organization and the prelims question. He has helped me throughout, and I can thank him enough for helping me in this journey. I thank you, Soumya. And for the prelims part, I would like to thank Anantharaman for organizing the molecular biology. He integrated the molecular biology and put some questions in. And I would like to thank Pradeep Reddy. I think Pradeep is here with us. He might have left, but he made the brilliant pharmacotherapy questions, which was case based in the prelims. And I would like to mention Simi Tahiliani. She made the oncology emergency cases. Those were wonderfully made exclusively for Harrison's. I found no errors in that. And again, I would like to thank Aditya Bhattacharya for integrating the surgical oncology part, all those tumors, CA breast, and their integration into MCQs. He has done a wonderful job, and he was the first one to submit actually. And with respect to orthopedics and pathology, Somil Anshal, he helped me a lot with bone tumors, and it was very structured. I could not put much of the bone tumors because he put some management part, but those were brilliant questions. And with dermatology and pathology, Mallikarjuna helped me. Actually, 3 questions of them were directly from his of connection round was directly from his questions. An integration of gynecology and pathology, and he also assisted us in this whole final round. It is Dhritiman Chatterjee. He helped us with the gynecology and path. Especially, it's so difficult to remember the stagings, and he made those cases within 1 day itself. And hemato-oncology, Kashish made, and he made it very simple questions like DLBCL, hairy cell leukemia. No such syndromes he mentioned. In fact, I was the one who came up with some syndromes. And palliative care, rehabilitation, risk factors, and epidemiology of cancer, Ronit Juthani took part. And CNS tumors, lung cancer, and eye tumors, those brilliant cases of adenocarcinoma in situ in the prelims, it was curated by Aparna S. So thank you. I have mentioned all of them, and now I would like the scorers and Raha to move on with the scores and rankings.
Okay, so he's modest as always. He didn't tell about himself. So it's his brainchild. We thought about it somewhere around July, maybe. He thought about it. So, and I was like initially, yaar, final year hai, to phad jayega, aise mat karna. Next year karenge, so something like that. Then later around September, I think we decided, okay, since we are at home, let's try it. So slowly things started materializing, and okay, so we have done it, and we have come
one
to the
second,
end
I'll also
also.
tell something.
Yeah, please.
Yeah, we have to congratulate Anirban and Samyajyoti Raha for this wonderful quiz. Actually, first it was their idea, Anirban's idea, then Samyajyoti Raha poured in. It was brilliant actually. Like some of thing I could contribute, but Anil, the work these two have put in, it's brilliant actually. Like they have final years going on, they have so many things to read, but still they have to taken time. They have approached many sponsors. They have approached the Shine Cancer Center. I think it's brilliant. I think we have to applaud them.
Like it was not just about conducting the quiz, but also about doing the whole lot of other work that comes with it. And like Anirban took the initiative of that, and like it's really awesome. It's really good how it turned out to be. Kudos to Anirban.
Thanks guys. Last but not the least, I would like to thank JIPMER, PR committee, and SSC committee. Without them, I would not been able to talk with the sponsors. I don't know what about sponsoring, but I know some basics because of Aditya Narayan, our PR head. He has contacted every Bhatia, Marrow, and other whichever sponsor has been possible. We conducted doc tutorials, but we ultimately came down to eGurukul. It's all the efforts of Aditya Narayan in sponsoring an SSC committee. Kudos to them because they helped us with every penny of the collection. They did not misplace. I think they did not misplace any money, and they contacted Shine and gave them all the money through Google Pay, and they provided us a receipt too. So, and we provided you the proof, and it is such a pleasure to like contribute to this, to such a cause. And I would like to thank JIPMER, PR, SSC, then, and again Agam. These people have just like worked with me with in every single point of this quiz. Every single point, every single poster, they have tried to broadcast it on their Instagram page, on their WhatsApp page, on their Facebook page. They have tried immensely, and they have live streamed this YouTube channel, which was supposed to be a very small private quiz. So I thank Agam, and again for Instagram promotion, I thank the IMA MSN Puducherry for doing such a great job. So now we'll move on to the scores finally, and you all can move on to have dinner. I think it's been too late.
Okay, so I'll not delay any further. So the scores are here. So in the 6th place, we have Team D, that is Dakshin. He is Dakshin and Aswin with 50 points, 50. In the 5th place, we have the team from JIPMER, that is Bikash and Saravanan. They're in the 5th place with 90 points. In the 4th place, we have Team E, that is Shagun and Ibrahim from MAMC. They're with 100 points. And the 3rd place goes to Team C, Balaji and Armaan from MAMC with 127.5 points. The 2nd place is again JIPMER, Vidya and John sir with 140 points. And there's no other guess left. So our winners for this entire event is the team from ZGS. So congrats to everybody. It's been late. Also, I received a message now. We have also been helped by a group of first year students. Like first year means they're now second year. So it would be bad to miss out them. Yes, their part has been, they have not been involved in the planning, but they have been very, very essential in the entire conduct of the quiz. Because without them, this quiz wouldn't have been possible. We are final years, we're busy with other stuffs also. But yes, they played a very important role. So that's all from our side. I think everybody of us are willing to end this now as fast as possible. Congrats to the winners again. Thank you. Thank you. Good night.
Can we take
Congrats to all
a
Congrats
participants
to
and
everyone
thank you
and
for the
thank you.
quiz.
Thank you.
Can we have
Congrats
a photo at the
everyone.
end?
Thank you. Bye bye. Good night.